Hello, and welcome to Missingness in Action, a Stanford conference on absent and missing data and the future of AI in healthcare. My name is Christian Rose, and I'm a medical informaticist and emergency physician here at Stanford University, where I work with my co-investigators, Drs. Italo Brown and Mike Gisandi, who you'll meet later. We'd like to thank Stanford University's Department of Emergency Medicine and the Institute for Human-Centered Artificial Intelligence for the opportunity to investigate the critical issue of how missingness affects the data we use for healthcare delivery and AI. The goals of the Missingness in Action conference are to share knowledge, generate new questions, and direct us to where research is needed. But we can't solve this issue alone, so we'd like to thank you for joining us today in this endeavor. Your participation is vital, and we encourage it. Throughout the conference, there will be polls and questions for you to respond to, and we're keen to learn from your questions and expertise shared in the comment box function of this virtual platform. If you'd like to keep the conversation going after the conference and to meet fellow participants, please visit the Slack space we've provided. With ever-increasing demands on our healthcare system, as well as records and health data growing rapidly in volume and velocity, machine learning has offered great promise to narrow the healthcare gaps that we see and to help us deliver high-quality care for all. However, the more we measure, the more we recognize that more data doesn't necessarily mean better data. Our most curated data sets contain gaps, as well as over- and underrepresentation of conditions or entire populations. Visits to healthcare institutions make up only a small part of how we experience health, yet the data garnered there are used to understand and predict the course of most diseases. Furthermore, even our largest clinical data sets contain information on only a small fraction of the population and represent those communities who have historically benefited from the greatest access to healthcare. The resulting imbalances may heavily bias results and limit their generalizability. But this is not a simple data science problem. It's also representativeness and representation. So today you'll hear from a spectrum of speakers across areas of expertise from data science, artificial intelligence, ethics, and design, just to name a few. In our first session, we'll hear from data scientists who address gaps in information and the impact these gaps have on the ability of our data to represent reality. Second, we'll hear from researchers who address these existing gaps by broadening clinical data. They develop and recruit information not captured by traditional mechanisms. Finally, we'll hear from experts working to build future infrastructure in this space. They'll touch on design thinking, data sovereignty, and data stewardship. We'll close with a global perspective, focusing on the importance of an ethical, holistic healthcare data infrastructure. So, thank you again for being here with us today. And without further ado, I'd like to introduce our first speaker, Dr. Ziad Obermeyer of the University of California at Berkeley. Take it away.
Thank you so much for having me. I'll just assume that everything's going well unless I hear otherwise with slides and audio and things like that. I wanted to talk about a particular kind of missing data that has become clear to me over the course of my own work in trying to build algorithms that help doctors make decisions. And to illustrate that, I want to just start by telling you about a particular decision that I, as an emergency physician, like Dr. Rose, struggle with a lot. And it's a decision that lots of doctors struggle with all over the healthcare system, which is the dilemma that you have when a patient comes in to the emergency department or to your office or to wherever with a range of subtle symptoms that could be heart attack. So, it doesn't always look like it does on TV, where it's a middle-aged white man clutching his chest and saying something about an elephant. Most of the time, it's actually quite subtle. And so when you see someone with a little bit of chest discomfort or a little bit of shortness of breath or nausea, that person could be having a heart attack right in front of you. Unfortunately, lots of patients have those kinds of symptoms coming into the ER or the clinic, and you can't test all of them. And that's where the dilemma comes from. You don't want to miss a heart attack, but at the same time, you don't want to waste money and expose patients to risk by testing them. And so the decision that every physician has to face when confronted with one of these patients is, do I do these invasive, dangerous, and expensive tests like stress tests and especially catheterization, which is the definitive test for heart attack, and get the gains if I catch a heart attack, but expose the patient to a bunch of bad stuff if I don't? So that's the dilemma I want to focus on today. So one way to think about this decision, which is the textbook way that like a kind of optimal decision maker would think about it, is, look, every patient that comes in has some probability of having an acute coronary syndrome, a heart attack. If I test them, I catch that heart attack, I treat them, and I get huge benefits to treating heart attack. And that's very well established in the literature over decades of randomized trials. If I don't test them, I miss that heart attack, and then their risk of adverse events, both acute and chronic, increases, and that's a huge problem. So the optimal decision maker, the rule that the physician wants to follow, is to test someone above a certain probability threshold. If the probability approaches 0, it's not worth testing them because you're just paying for the test and exposing the patient to risk. But as that probability creeps up, you want to test them so that you can confirm that they're having a heart attack, and especially so that you can treat that heart attack in the same procedure, which is catheterization. So why is this a good machine learning problem? Well, because if you can predict that probability, you can really help the physician avoid two kinds of errors. One is testing people with a very, very low likelihood of having a positive test. And two is failing to test people with a very high likelihood of testing them if positive. So I think there's huge scope to improve physician decision-making, as I'll try to convince you here. So one of the things that you have to confront in any application of machine learning to medicine is, what is the thing that I'm talking about, and how do I measure it? How do I know if a patient has an acute coronary syndrome? Now, this is actually easy in one population, which is when I do a catheterization procedure, I can visualize the coronary arteries, I can see if there's a blockage. So in that set of patients that's actually tested with these definitive tests, we see the test results. And I want to start there because that's the easiest problem to deal with. So what we do is we train a machine learning algorithm to learn from all of the patients that physicians test. They test 2 or 3% of patients that come through the ED. About 15% of those tests come back positive. And so the algorithm is looking at that patient's medical history, learning everything about the things that are more likely to have that test come back positive, and then making a prediction on a new set of patients that the algorithm has never seen. And so when we do that, we actually see some amazing results. So this graph shows you on the x-axis patients ranked from low risk on the left to high risk on the right. And they're put into bins. So they're just 10 bins of people from lower to higher probability. And on the y-axis, you see the yield of testing. So in that bin of patients defined by the algorithm's predicted risk, how many of them have a positive test for heart attack? This is kind of catheterization, identifying a blockage and leading to a stent or another revascularization procedure. And you can see that that line is sloping up pretty steeply, which is great. So on the bottom, on the left side of the curve, you see that these very low predicted risk groups have a super low probability of testing positive. And when you calculate the cost effectiveness, it's insanely low. So this is very low value testing over testing. And on the right, you see that people have a very high likelihood of having a positive test. So over 50% of the people in the top bin have a blockage in their coronary arteries. Physicians are testing all of these people. So physicians are worried enough about every single one of these patients to make them want to expose them to the risks and the costs of these invasive tests. But 2/3 of the time, the algorithm says, don't do this test. It's going to come back negative. And sure enough, when the physicians go on to test those people, it's super, super low value as measured by that cost effectiveness. On the other hand, if you look up at that top bin, you see, okay, well, these people, about 50% of them, over 50%, are coming back positive. So that brings up the question of whether physicians are testing a bunch of people that are very high probability. Are physicians also failing to test patients like this? So we can calculate this probability. We can apply the algorithm to the people who have not been tested. And when we look at people who are in that apparently very high risk group, about half of them are actually untested by physicians. And so that might make you wonder, well, are physicians failing to test these very high-risk people in the same way that they are testing a bunch of low-risk people? So are they making these two types of errors? So here's where the missingness comes in, and I think this is a really, really important point. So remember, in the tested patients, we see the test results. So we can train our machine learning algorithm and we can validate it. When the machine learning algorithm makes a prediction, we don't need to rely on assuming the algorithm is right. We can look at the test result to see if the algorithm was right or if the physician was right to test this patient. And what we saw is that 2/3 of the time, when the physician says test and the algorithm says don't test, the physician is wrong. In the untested, things are a lot harder because naturally, in the untested patients, you don't have test results to look at. And that is the missingness that I want to really focus on today. This turns out to be a huge problem for machine learning algorithms because the algorithm can generate a prediction for those untested people, but we have no easy way of validating those predictions in the untested people because we don't have the test results. Now, one way that people have tried to get around this problem is basically just by assuming that the algorithm is right. So the algorithm sees a lot of stuff about these patients in terms of their past medical history. It's making a prediction. Sure, we don't have the test result, but the algorithm is really good in the tested people. So let's just assume it's right in the untested people. And that is not at all what I would suggest doing. There is a very, very good reason that you cannot just take algorithms that are trained in the tested population and apply them to the untested population. And let me illustrate why by observing that, sure, imagine a very high-risk patient. And sorry, these slides font got messed up. So let me just paint the picture for you of a 64-year-old man who's had a heart attack before with a high recent cholesterol. The algorithm views this patient as very, very high risk. So when the physician fails to test that patient, we and the algorithm think like, oh, stupid physician, letting this high-risk patient go through the ER without testing them. What the algorithm and we don't see is what that patient's chest looks like, which is maybe there's a knife sticking out of it or a huge burn injury. So the physician might have left that patient untested for a very good reason that the algorithm doesn't see. So it's very, very dangerous to just assume that the algorithm has gotten it right without validating those predictions. So let me talk about two ways in which we can get around this missing data problem. And both of these ways, I think, rely on an intersection of understanding the medical context of the algorithm and the patients in whom it's predicting, and also knowing a lot about the institutional context of how care is delivered in the emergency department. And so I think those are two things that the people in this virtual room are going to be very, very good at doing. And that's why I wanted to mention these two workarounds for this type of missing data. So the first thing we can do is to say, okay, sure, we don't have the literal test result in untested patients, but we do have longitudinal electronic records that let us see, okay, well, what happens to this patient, for example, over the next 30 days? So we can look at all of these untested patients and take out all of the ones who are, old and frail and people that the physician has, ordered a troponin test on in the ED and seen a positive result, but still decided not to send the patient to the catheterization suite. So we're going to look at these untested and apparently unsuspected patients, and we're just going to follow along and see what happens to them in the 30 days after their ED visit. And what we find is that, again, when we rank order those patients from low risk on the left to high risk on the right, these high-risk people go on to have very high rates of bad things happening to them in the 30 days after their visits where they weren't tested that suggests that at least some of them had a heart attack that was missed. So you have a 16% rate at 30 days of a combination of people coming back in and getting diagnosed with heart attack when they weren't diagnosed the first time around. People having cardiac arrest, needing defibrillation, CPR, being diagnosed with VF or VT, or just dying out of the hospital. So 16%, whereas the clinical decision rules say, well, if someone has a rate of these outcomes of over 2% of these major adverse cardiac events, you should strongly consider testing them. So these patients have event rates that are way above what guidelines would suggest testing. And that's one way to try to get around the fact that, sure, we have missing data about test results, but we can triangulate the underlying thing that we're trying to measure by looking at other metrics. The second way to get around the missing data problem is to use what's sometimes called the quasi-experimental or natural experiment toolkit. So depending on the particular time that you walk into an emergency department, you're going to see a different team of nurses at triage, nurses in the back, emergency physicians, physicians in triage. And that constellation of people that you see has huge implications for your likelihood of getting tested. So whether you walk in at 6:59 a.m. or 7:01 a.m., you're going to see a totally different team, and those teams are going to have different testing rates. But the patients are kind of similar because they're walking in at around the same time. So we can ask two questions. First is, if we look at all of the patients who walk in on the high testing shifts versus the low testing shifts, do they do differently? And the answer is no. So there's no difference in their rate of heart attack downstream or death rates at 1 year. And that looks a lot like wasteful testing. So we test more, we test less, patients do about the same no matter what. But that ignores a very important fact, which is the vast majority of patients are low risk for heart attack. So let's use the algorithm to now zoom in on the 1 to 2% of patients that are very, very high risk according to the algorithm. When we run that same playbook, but just look at the high risk people, we find that if a high risk person walks in on a high testing shift versus a low testing shift, they're about 30% less likely to die over the next year because they're far more likely to be tested, have heart attacks diagnosed, and have the appropriate treatment delivered. So that's not wasteful testing at all, but it does use this variation in care that doctors are generating in the healthcare system every day. That lets us make one really important conclusion about the way doctors think, which is that when we compare those low testing shifts to the high testing shifts, so I bin patients into these 4 bins based on whether they are walking into the ED in a high testing shift or a low testing shift. And then I show you the testing rate on the y-axis, and on the x-axis is the algorithm's predicted risk. So you can see that on the left side of the graph, those lines are separated. So low risk patients are getting tested much less when they come in on low testing shifts. The problem is that when they are high risk patients, they're also getting tested less when they walk in on low testing shifts. So when physicians test more or less, we test everyone more or less. We don't test the high risk patients more and the low risk patients less. We are very coarse in the way we behave. We test everyone more or less. And that's true at the hospital where we ran this initial study, a hospital in the Boston area where I used to practice. And it's also true in national Medicare data, which is the graph on the right. So let me summarize by saying that physicians appear to be making mistakes when they're predicting someone's risk, and that misprediction is a driver of 2 kinds of errors: overuse and underuse. When we run what the algorithm would do compared to what physicians are doing, we would only keep about 40% of the tests that doctors are currently doing, but we'd also add back in about 16% of tests that doctors are not currently doing on patients who are currently untested but are very, very high risk. So it's not so much about, oh, we need to test more or less, or there's low value care or high value care. It's this particular patient is high risk or low risk, and we should test her more or less. And in closing, I'll say that, I think there's a lot of emphasis on machine learning in healthcare as a product, like an algorithm or a decision aid that you can integrate into your EHR. And we're working with a large health system now to implement this algorithm as a huge cluster randomized trial across about 50 hospitals. And I think that's very valuable. But what I like about this paper and the work that I did is that it's also a very powerful new tool for understanding our healthcare system and for seeing where physicians are making mistakes and teaching us to do better. So you can link the paper itself is a long monster paper that you can peruse at your leisure. It's on my website, which is ziadobermeyer.com, and really looking forward to the panel discussion.
Okay, well, thank you, Ziad Obermeyer, for your illuminating talk, as always, directing our attention to the importance of having the right labels. My name is David Kim. I'm an ED physician and researcher at Stanford, and it's my pleasure to host our first panel on missing data with Latrice Landry, Maya Mathur, and Pranav Rajprakash. Data is always missing and is almost never missing completely at random. And this makes missing data a ubiquitous scientific problem on which each of our panelists have a unique perspective. Audience members, please put your questions in the chat and we will address as many as possible. First, I would like to ask each of our panelists to briefly introduce themselves, and then we will get to some questions. And maybe we can start with Latrice.
Thank you. And thank you for inviting me to talk about the problems of missing data in molecular diagnostics. My name is Latrice Landry. I recently joined the faculty at the University of Pennsylvania in the Department of Genetics. I study equity issues in the translation of biomarkers in clinical genetics, and I'm happy to be here.
Thank you, Latrice. And Maya? I think Maya might be muted, or I can't hear Maya.
I can't hear Maya either.
Rachel, can we assist Maya with the audio issue here? Oh, there she is. Okay, I can hear you now.
How are we now? Sorry about that. I wasn't actually muted. I'm Maya Mathur. I'm an assistant professor at the Stanford Quantitative Sciences Unit and the Department of Pediatrics. I'm a statistical methodologist with work that focuses on issues of bias and evidence synthesis.
Great, thank you, Maya. And Pranav.
Hey, I'm Pranav. I'm an assistant professor in the Department of Biomedical Informatics at Harvard Medical School. And I'm a computer scientist by training. I did my PhD at Stanford where I was until recently.
Thank you, Pranav. And oh, great. We're happy to have Ziad on the panel. And Ziad, I think probably everyone just heard your excellent talk, but in case anyone didn't, if you could just give a very brief introduction.
Thanks, David. Ziad Obermeyer. I am an associate professor at Berkeley. I trained as an emergency physician, mostly doing research now, though I'd like to be doing more clinical.
Perfect. Well, I'm very happy to have you all on the panel. And to get things started, I'm just going to ask you each a question or two pertaining to your area of expertise, and then we can move into general topics for the whole panel. So let's start with Latrice. You've done a lot of work on disparities in molecular diagnostics. Can you tell us a little bit about where these disparities come from, why they matter, and what you see as the remedies?
Absolutely. I think when we think about molecular diagnostics, it's a little bit different than other aspects of medicine, mainly in that it has a direct translation when it comes to sort of clinical practice. So when you think about molecular diagnostics, I like to think about things in a translational spectrum where there's everything from the discovery of a biomarker, and then there's sort of thinking about cohort studies and identifying or translating the biomarker to detection in humans. Then there's clinical trials, and then there's sort of health services research and implementation science, where we think about how a biomarker, which is maybe now sort of available as a diagnostic or a therapeutic component, And then you can think about it from a sort of public health standpoint and sort of what is the biomarkers overall impact on health. And so when I think about sort of disparities or the missingness of biomarker research and how that impacts patients clinically, I'm thinking about that entire spectrum. And what we found is that there are issues with inclusivity and representation of diverse populations in biomarker research throughout the spectrum. So from the discovery standpoint, the way that impacts patients is our diagnostic tests, especially in molecular diagnostics now, are sort of we have targeted panels, we have increasingly expanded availability of tests, and we might have biomarkers that are missing from that test because they were more prevalent in a population that was not incorporated in the basic science research. We have issues with inclusivity and representation in clinical trials. Well, we may have missing data on sort of safety and efficacy of a certain biomarker in a certain patient population because they weren't represented. And then we also have issues in the health science research and implementation science where we know and we've shown that lots of patients are not getting access to the molecular diagnostics. And there's a whole host of reasons. So I think when I think about missingness of data in molecular diagnostics, I think it is an issue that transcends the entire translational paradigm of biomarkers and is something that requires a concerted effort amongst researchers and clinicians to address.
Thank you, Latrice. And I'm just going to intermittently intersperse some missing data 101 in here to the benefit of our mixed audience. So what Latrice is pointing out is kind of a classic problem for missing data, which is that if observations are systematically missing for one population that has numerous ill effects analytically, biasing estimates, producing representativeness, and that also underlies the point that to the extent there are practical, clinical, health, economic benefits to science, this is a moral and ethical issue as well, and I think that's a topic that we're going to return to throughout the panel. Maya, your work on missingness spans sensitivity analysis methods for missing data in individual studies and publication bias in meta-analyses. I would like to ask you, as a methodological expert, what aspects of missingness can be addressed by better methods and what kinds can't? And what do you see as the barriers to the adoption of optimal techniques to handle missing data?
Yeah, so in terms of the types of missing data that can be addressed, I see one important frontier right now as developing methods or sensitivity analyses that will better address not missing and random data. So right now there's kind of a nice suite of methods that can deal with missing at random, which means that when data are missing, the probability that it will be missing is, and also the distribution of other variables is random conditional on variables that are observed. Not missing at random would be situations where essentially the missingness actually depends on missing variables themselves. And that latter situation is really hard. So there are some methods out there, but they do typically require some fairly strong assumptions on the actual mechanism of the missingness. And so I think sort of the frontier would be kind of working on either sensitivity analyses or sort of worst case bounding approaches that don't necessarily require such strong assumptions in those settings. And then, yeah, I guess your second question was barriers to adoption. Yeah, I think this is a really interesting one. I think one challenge is sort of ease of computationally implementing methods. So there are some really good methods out there that are just not necessarily that easy to implement. Even multiple imputation has some great software behind it, but also isn't necessarily straightforward to do for large data sets in practice, and it can be kind of fragile with highly collinear covariates in the model. So I do think kind of methods that are relatively easy to apply, easy to interpret with kind of relatively transparent assumptions is helpful in that regard.
Perfect, thank you, Maya. And again, I'm just going to apply a simplifying filter to some of what Maya said about multiple imputation. This is the idea that there are many ways you could fill in missing data points from well, you could delete observations, which is deleterious because you are ignoring potentially systematically certain types of cases, or you could try to fill in missing variables in naive methods, like using the mean or some other measure of central tendency or front or back filling. And what Maya meant multiple imputation is generally seen as one of the more rigorous methods because it uses the existing data to make an educated guess about the likely characteristics of the missing value, as well as the distribution of possibilities of that value. But as Maya mentions, one of the barriers here is that this imposes some computational and analytic complexity, and also forces us to think of our data sets as drawn from probability distributions, which they are, but which is still not probably the natural habit of thought for most analysts. Thank you, Maya. And Pranav, your work in AI and machine learning has spanned so many domains, from radiology to our collaborations on continuous physiologic monitoring data. With your interest now in moving towards clinical validation and multi-site generalization, can you speak to how the problem of missing data affects generalizability and clinical application of machine learning models?
Well, I think of first we need to measure, and if we can't measure how well we can generalize algorithms to different patient populations, we can't actually improve. Over in the non-medicine side of things, we think about how do we build algorithms using data from several sources that will apply to more targets out of my sources. Or if I have limited data from one new hospital site, how do I use that to be able to have my algorithm generalized to multiple sites? I think these very interesting and important setups that are going to reflect the way we're going to build with one hospital's data and expand to more and more hospitals first needs for us to set up benchmarks where we're able to say what happens when you train on one hospital, what happens when you train on 3 hospitals, 5 hospitals. Doesn't matter where those hospitals are and how taking those models will actually help other hospitals. And so that's the kind of thing that I think about.
Thank you, Pranav. And Ziad, I have a related question for you. So your model in your recent quarterly Journal of Economics paper, like many machine learning models, uses a large number of variables, which will entail missingness across these many classes of information. Is missing data more or less of a problem in models like this with huge numbers of variables, and why?
Yeah, it's a really interesting question, and I think one way that I think about missingness is the missingness in the things that you're using to predict the variable of interest, or is the missingness in the variable of interest itself? And so, in our setting, like it's, we define the ground truth for heart attack as you have a catheterization that shows a blockage in your artery that a cardiologist decided to open up. So that's our definition of ground truth. That, as I mentioned, is present in all the people who were tested, and it is absent in 100% of the people who were not tested. And that's like the huge missingness problem that we try to solve and try to deploy these solutions for in our paper. So that's kind of when the variable you're trying to predict, the label, is missing. I think on the other side, when predictors are missing, I actually think that's kind of an easier problem, because there, yes, there's often missingness. And so we use 16,000 variables, and a lot of them are ICD codes or labs, and some people don't have the labs measured, and it's super complicated, but that's exactly the kind of complexity that ML is great at sorting out. So the particular kind of algorithm that we used can actually use missingness as itself being informative. So the fact that a patient has never had a troponin checked is informative, and it can capture that and fold it into the predictions in a very useful way. So I think when the missingness is in the predictor set, you've got a much easier problem than when it's on the left-hand side as the label itself. And so I think that's maybe the way that I think about missingness on the two sides of the model.
That's a great point, and I think as is often the case, and as your previous work speaks to, it probably also depends on the nature of the outcome being predicted. Obviously, if it's missingness can be informative, and that may be maybe to the overall benefit of the model, or it could be to the detriment of patients if the outcome being predicted is some benefit to be assigned or healthcare resources to be allocated, as you've eloquently written about in your other work. With those introductions, I'd like to get to questions from the audience for the whole panel. My colleague Maya Yadam asks, do we understand the nature of the biases in data sets enough to develop methods to balance the bias towards equity in disease or treatment outcome predictions, or is there an earlier opportunity to explore the bias itself first? And this is open to the whole panel.
Maybe I can start out. So I think let me use the example of imaging. So let's say I wanted to have algorithms that could interpret a medical image, let's say a chest X-ray, and I wanted to work on everyone's data across the world. So one difference that I learned about when I was thinking about this was that in Europe, different acquisition parameters are actually defaults compared to a majority of the setting in the US. Now, the fact that I know that allows me to now collect a data set where I can make sure that I can pull the acquisition parameters now that I know which ones vary. That's important. So I think the task of going about trying to identify the potential sources of biases to make sure that we can capture the measurements related to those sources of biases, I think is very important.
I'd say in genetics, it's a little bit more complicated, or it's complicated in that the issue around missingness isn't just in sort of the clinical data. It sort of starts back into the discovery research. And so since I think the most recent estimates are somewhere between 70–80% of all genetics research has been done in populations of European ancestry, our evidence base is really based on a singular population, and in some diseases, holistically based on that one population. And so there are these complications in genetics and understanding the relationship between a genotype and a phenotype, and understanding more complexities around the genomic architecture where the basic science understanding is not there. Once we, and we are, there's a lot of endeavors to try to sort of redo or sort of add to our knowledge, recruit more diverse populations, establish a more complex human genome reference that we can use. But once we get our basic understanding sort of clarified, I think then we can use those tools. It's sort of that question, I think, that Pranav was sort of getting at, in terms of if you don't have the question or you don't know sort of what's missing, you can't really answer it. And right now we have to do a lot of research to sort of figure out what the baseline understanding is and what the differences are between population groups, to be able to apply that clinically downstream. There's a lot of work in that space, but it's going to take some time.
By the way, hey Maya, nice to see you again. I think the last time I saw Maya was in the emergency department at the Brigham. So it's a great question, because I think that I've worked on algorithmic bias, and one of the things that I learned from that work is that a critical part of measuring bias and quantifying it and seeing if it's present is defining what is the thing that we're looking for. And once we have the thing that we're looking for, it's very easy to compare, okay, well, is it different between black and white, male and female, like whatever your groups of interest are. But a lot of the bias comes into the things that we choose to look at. And so in some of the work that I've done, for example, algorithms are supposed to be predicting who's going to get sick, but their metric of sickness is utilization of healthcare resources. And so when we choose that as our measure of sickness, we're disadvantaging people who lack access to healthcare, because needing healthcare is not the same as getting healthcare. And so I think being really precise about the metrics that we're using for bias is super, super important. And I think it speaks to your, I think the notion you were bringing up of like really getting upstream as far as like how we understand and define bias and how we measure it, and making sure that our measures are themselves fair before we even start doing the comparisons across groups.
And I have a follow-up question to this, which anyone can address. It seems like we have tools to identify deleterious biases, and even if we don't, we often think that we know them when we see them. But the converse, in efforts to debias algorithms and outcomes, how do we know when a data set is representative, or when an algorithm is adequately unbiased? Presumably that doesn't mean that we get identical outcomes for all possible groups.
Yeah, I mean, it's challenging without having some kind of external validation sample, or alternatively, at least a really broad range of covariates that we think are essentially explaining any differences, which are called effect modifiers, so variables that affect the treatment or exposure effect. Sometimes we can make a little bit of progress if we want to make assumptions about kind of how strong the effect modifiers are, and the proportion of missingness that we have compared to the actual target population. We can kind of reason along the lines of, well, if I have 80% of the people who I would have wanted in the target population, and any effect modification isn't really that strong, then perhaps the effect I've measured is only biased by a certain amount, for instance. But without either assumptions or external data, it's hard to really make progress in that setting.
I'll say this is a really great question in the space of clinical genetics and, for instance, polygenic risk scores. There's been a lot of debate. Do you say that the issue of representation or generalizability is in terms of clinical implementation, is something that has to be determined before something is available? And I think that regulatory bodies have struggled. I did a fellowship with the FDA, and their issue was to determine whether something is generalizable or not hasn't been a part of their process for sort of products to market. And so the question becomes, do you require companies to, in the biomarker space, to prove that it's generalizable? And that doesn't seem quite well, because a lot of companies suggest that increase their costs, right? And so they would come back with, you need to demonstrate to us that there is a difference, right? And so this is issue of which comes first, the chicken or the egg, in terms of missingness. And so in genetics, we've sort of come into a space now, and it may change over time, but the issue is, do you have a sort of a line at the end of a diagnostic test that says this may not be generalizable? Or do you not provide it at all if you think that it's not generalizable? To give an example, we had a implementation study of a genomic, a genome-wide sequencing, or whole genome sequencing in a patient population, to try to see how it might impact care. And for the polygenic risk scores, some of our collaborators who generated the scores said, hey, we didn't have enough data to generate this risk tool and make it generalizable to all populations. So on the patient report for this study, I just want to have a line that says there weren't sufficient data in non-white populations, and so this is not available to this participant, but it's on a clinical report, so it would be patient if this were to be implemented. And then others had said, well, we don't really know if it's generalizable or not. We don't have sufficient data. So we just want to at the end of the test that says these data may not be generalizable, right? And you can see that there's a lot of consideration and concern about this. On one hand, people feel that the elimination from the test of the patient reports deprives a patient population of access to something that other populations can have. And it's been considered, you sort of like race, I think there was an MIT review that called it white people only DNA test, right? And then the other end is that the fine print isn't something that everyone reads. And are you really going to put it on a primary care physician to sort of figure out whether this is relevant to their patient or not? And so I think that we're in a real space where we don't know, but I think that is a space of development that is needed, where we might have tools that can accurately predict in real time, maybe clinical decision supports to allow providers to know, hey, this is something generalizable to your patient as we see your patient in the system.
Great, thank you all. Along these lines, some with well-known examples of biased algorithms. Some commentators have suggested that on sensitive predictions, algorithms should be inducing missingness of a sort and not using sensitive demographic variables like race or sex or any other characteristic on which an outcome might be thought to be biased, and others adopt the contrary position that it's never justified to do so, and that that's the bias is to be corrected elsewhere, usually with more data rather than less. Can any of you speak to your experience with this debate? Again, the question of whether there is ever a case to exclude information in the interest of debiasing predictions or data sets.
Can just maybe offer one observation, which is that there's just in my own work auditing algorithms for bias, I haven't seen any relationship between whether I've found an algorithm to be very biased or unbiased and whether or not it includes a race adjustment explicitly. I think a lot of our intuitions for algorithmic bias come from basically analogy to human bias, where it's like, oh, I see something about you and I treat you differently. And that is not at all how algorithms work. And so, for example, like in one example that we studied, which is a very widely used population health management algorithm, the company that made that algorithm very clearly decided not to include a race variable or proxies for race like zip code in the algorithm. That did not prevent that algorithm from being extremely biased. I think in other settings, algorithms that have a race adjustment can actually accurately represent differences in need, for example, between Black and white patients. So we actually would not particularly want algorithms that treat everyone the same way in the healthcare system, because on average, Black patients have higher needs than white patients. So an algorithm that was truly blind to race and that treated everyone equally would actually be very biased because of the differences in patient needs across the landscape of privilege and access and racism that characterizes our healthcare system. So I actually think, in all of the work that I've done, trying to hone in on a substantive definition of what bias in an algorithm would look like in a particular setting with respect to a particular decision, that is hard work, but it's really necessary work. And I think it's much preferable than relying on these proxies that people, have unfortunately started to use, like, oh, if there's a race adjustment, then that equals bias, when empirically that's not really the case.
Yeah, seconding that, I think there's a number of really interesting cases that are maybe not that well discussed, where adjusting for certain variables can actually essentially debias treatment effect estimates in an analysis that actually is complete cases only. So in other words, not doing something like multiple imputation, but rather only including complete records. And so even though we typically think of an analysis like that as being more biased, there are cases where that actually will work, but a method like multiple imputation will not work if we have the right variables adjusted in the model. And figuring out whether we have the right variables is tricky. It depends on the structure of the missingness. How exactly does it arise? But yes, speaking to Ziad's point, certainly there are situations where choosing the right adjustment variables is critical.
Just to add to that, I think things also get interesting in very high dimensional spaces. So when we're looking at images, you might be aware of the recent work showing we can detect race from chest X-ray images. And just an interesting case study. So we might say we want models not to be specific to devices. So one way we might do that is to tell the model which device an image comes from. And funny study is a few years ago, we were looking at detecting clots from ultrasound videos. we didn't pass in any sort of device variable or anything. We got almost perfect accuracy. So we looked at what was causing that perfect accuracy, did some sort of saliency maps. And then for all images, we were looking in the top right corner. What's the top right corner? It was the type of the machine. One of the machines from the hospital is where there were almost no positive cases. The other one where most of the positive cases came from. This was a case in which we did not explicitly feed in the device, but it's something that could be learned from the high dimensional space. And that was a lesson to me in terms of high dimensional spaces cause a lot of issues for trying to take variables out that you may not want to rely on.
Yeah, that's a great point, Pranav, and again, a case in which inducing some missingness by removing some artifactual or irrelevant data from the lens of the algorithm is obviously to our benefit. We have some questions from the audience here. Nikesh asks if any of you have ever had to stop a project due to lack of data, or more generally, I would ask at what point do you decide that a missing data problem is not to be solved analytically, but requires the collection of additional data?
I'll go and just say to Nikesh's question, I think that the example of not returning the polygenic risk score to patients who did not identify, or participants in the clinical research study that did not identify as white, is a way of stopping, right, sort of moving forward in that group because of a issue of missing data. I do think that in a lot of our projects from a research standpoint, and it'll be different in a sort of a implementation within your EHR, but from a research standpoint, the projects always move forward, and you publish and you talk about the issues that come around. And I think in an implementation science space, and it's really important to capture that so that we can, as a collective group, understand issues that are arising when people are actually trying to implement these into practice. But I think from a research standpoint, what I've seen is that things move forward in the genetic space, and then we're trying to talk about it and sort of figure out ways in which we can conduct studies to improve the issue, but not just stop completely. But that's different if you're direct translation into your AHR. So.
And along these lines, we've recently seen a push towards so-called data-centric AI, placing less emphasis on algorithm development and more emphasis on collecting, curating, labeling data. Is this the solution to missing data? Are there special considerations that need to be addressed to speak to the problems that we've discussed today?
So maybe I can start on that one. I think one way to think about that can be, what is data that can be collected easily and data that can't be collected easily. So for instance, I think about annotations as being very hard to collect, but raw images as being as easy as doing a Google search and adding those on. But then what is the way that we can think about methods such that we can use data that's easy to collect to improve our methods, but then not have to rely on getting more of the kind of data that's hard to collect? And so one class of methods that does this well in learning is self-supervised learning, where you're able to take into account all of the unlabeled data to improve your understanding of the structure of some high dimensional object, whether that's an image or a sensor signal. And so that's been very exciting. But obviously that's not possible to do if we're looking at the class of hard to collect problems. It's not like someone can say, I'm going to fix a model and I'm going to solve this problem by getting lots of doctors to label lots of data or make lots of phone calls to patients. That's just not feasible in a lot of settings.
Great, thank you, Pranav. We have a question from Paul in the audience addressed to Ziad, but I think this probably touches on some issues that everyone can speak to here. In the never tested troponin example, how will the model differentiate between the missing data scenario of the patient with a knife in the chest versus a doctor who is a low tester? Does the model learn through the data that this doc is in the low testing group and uses that information to predict whether the patient is likely to have an MI?
Paul, I love this question because I think it speaks to one of the things that it's a much broader theme about what is the best way to design a system with humans and algorithms working together. And the reason that's your question brings us up is because you bring up this type of data that's missing in a particular way. It's not anywhere in the data. So, like when a physician notices that the patient's like, it just doesn't look right, usually the physician doesn't write that down. But that's just one instance of like a type of variable that a physician sees and knows and uses, but we don't see. And the algorithm doesn't see because it never makes its way into the note in a structured way, or it doesn't. So there's a whole class of variables that not only are they missing, but they will be missing for a long time until we get continuous streaming video from every room in the hospital, plus continuous monitoring and everything else. So the physician is always going to see things that we don't. And that stuff is going to be useful for the physician's decision-making. And that's why, in my view, thinking about algorithms replacing doctors is not the right way to think about this at all, because the physician and the decision maker who's on the ground doing stuff is always going to know more than the algorithm. If the algorithm and the physician had access to the same information, the physician will always lose. But the physician always has more information than the algorithm, like 100% of the time. Sorry, not 100% of the time. There are some edge cases where that's not true. But that's why I think, in my view, the algorithm is always going to be feeding processed information to the physician. And the physician is always going to need to have the ability to overrule the algorithm because of exceptions that the physician knows how to handle and the algorithm doesn't, because of additional information the physician has and the algorithm doesn't, because we have a causal model and understanding of what is going on with the patient that the algorithm does not have. So all of those things bring up the fact that there's stuff missing from the data sets that algorithms are trained on that puts a ceiling on the autonomy that the algorithm is going to be able to achieve. And that's why I think, the augmentation frame it's not just about like, oh, we need to have like human emotions and fuzzy doctors being nice to, that has nothing to do with it. This is a pure data point that there is data missing from the algorithm. And if you ignore that missingness, you're going to have catastrophic results.
Thank you for that, Ziad. And along these lines of how we actually see these algorithms entering practice, which is still a relative rarity, and how they ought to be interacting with humans, physicians, and otherwise. I'd like to ask all of your thoughts on what you see as smarter, desirable approaches for this to happen. One example from the literature that I thought was impressive was Sue and Lee's group at University of Washington had this paper advancing the notion of cost-aware AI tailored to direct the human interacting with the algorithm to the missing information that would be most relevant to making a discriminative judgment or to making a more accurate prediction for a given patient. What are all of your thoughts on how the human algorithm interaction can resolve some of these issues or decrease the problems of missing data?
Well, I can start. I think a sense of the uncertainty associated with a prediction might be a good place to start. In general, I think the interface of a decision coming back with, I'm not sure, is fairly useful in helping someone calibrate to say, I really shouldn't trust the decision of the algorithm. But at that point, you might as well ask, okay, why doesn't the algorithm just say, I don't know, rather than saying it's 60% and I don't know? Well, it's because you could consider the output being 80%, but could be 60, could be 90, or 80%, but could be 0, could be 100, as still saying two very different things. The first one maybe still allowing the physician to make a more informed judgment than the second one saying, kind of don't look at me at all. So I think that could be one way to tackle it. But of course, it comes at the cost of possible information overload. I don't think anyone wants to see more numbers than they're currently seeing in any assistive tool.
I personally live in a land of pathology and sort of laboratory assays. And so my view of this is very different because when I started my clinical training, there was a danger we're going to be replaced by the algorithm, right? You shouldn't even pursue this. I mean, I think the whole pathology sort of field was, sort of concerned for quite some time, especially in certain aspects. And genetics is one of those where people feel like they were going to be replaced by the machine. I will just say in practice, though, I think the thing that I've sort of held on to as sort of the important component to think about is that medicine is transformative and it's dynamic and it's not the same, right? So the algorithm, to Zaid's point, is something that can be trained on sort of an existing evidence base, things that are already known and understood, but the human will always have more knowledge. And as medicine transforms, and in the space of genomics and molecular diagnostics, it is transforming at a rapid pace. The algorithms cannot keep up. They will need people to help sort of cultivate the way in which they're shaped and the information that gets collected and the observations and the variables that we put into them as information or data points to be collected and observed. And so I think in this space, especially in sort of pathology and laboratory medicine, it's important to sort of think about ways in which the human gets put into sort of a quality control and an evaluation process, overseeing the development and implementation of algorithms clinically. And when things are introduced early, and sort of early stage introduction and implementation, you do need almost sort of daily observation in clinicals to go alongside of it to ensure that they're performing according to expectations or with the clinical or human component of the sort of application or implementation would be. And so I do think that it is a partnership, but I do think it helps expand capacity and it helps us utilize the other advances in technology in a way that which we wouldn't be able to do with just a singular component. But I think decision support is a part of that. But I do think that there is a workforce around sort of quality and control in the implementation process that needs to be sort of cultivated and sort of enabled to do that.
I think you're muted, David.
Oh, thanks, Pranav. Thank you all for those responses. I think we have probably time for a couple of more questions from the audience. In fact, I see one from Christian Rose here directed to Latrice, asking, we know that many genetic studies are focused on founder populations and other specific populations, making it more likely that we'll see a correlation to a disease of interest. How do we expand the scope of these studies to make them more representational or accurate to all populations?
Yeah, I think in this space, it's sort of important to sort of highlight. There are a lot of genetic research studies that are focused on founder population. That's in the discovery mode, right? And so the idea there is that you can identify the rare, right? The rare variant and the rare phenotypic association. And a lot of companies really like that because it allows you to identify something that you would have a hard time identifying and sort of it would get lost in the noise. But I think that's specific to certain aspects of genetic research, and it's not something that, for instance, in common complex disease, that you would be able to take that approach. And so right now what we have in genetics is sort of an expansion on all accounts. There's a lot of efforts to increase diversity and research in sort of these large genomic repositories, learning health systems, genome biobanks, right? So just trying to collect tons and tons of data and try to link that to clinical phenotypes, either through electronic health record access and different aspects of that sort of have been developed, not just in our country, but in other countries, to try to help scale so we can understand the rare versus the complex. I think that founder studies are not going to go away because they do allow you an opportunity to sort of deal with or identify or refine your study design to amplify a signal that is a rare signal, but a signal that might be important maybe for a pharmacological development or diagnostic. So I think that these things are going to happen in tandem, but I do think that the sort of founders research study alongside the sort of more complex data or research that's happening with these large genomic biobanks that are just getting bigger and bigger. But I think the key here is not just increasing size. I do think that there is some methodological enhancement and development that needs to happen alongside just getting bigger and bigger data sets, which is the approach of genomics right now. And I think that using some really refined AI approaches, which haven't really all been developed because the space is just rapidly developing. And so I think as we take things from other areas of research and AI research and apply them to genomics, but also develop new methods to sort of deal with the data, I think that that will help us develop more complex ways of sort of analyzing genotypic and phenotypic relationships.
Thank you, Latrice. And I think we probably have time for one last question, and we have one from KS Anand in the audience here. I think this is probably directed at Ziad, but really speaks to what all of you have spoken about. How would you include the different levels of clinical experience for MDs into the algorithm? Experience might entail greater awareness to variations in presentation, or could just be just entrenched and reified ignorance. And I think more broadly, this applies to all situations of how the interactions with these sorts of algorithms ought to vary by the user.
Yeah, it's a great question, and one of the things that we looked at in the paper is variation in performance by a number of different things about the doctor, like where they went to med school, how long they had been practicing, demographics, just like a bunch of, volume, how often they practiced. And there was only one thing that stood out, and it was essentially years since residency. So more experienced doctors actually were much better at testing the high-risk patients and not testing the low-risk patients. So the slope on that curve just went up and up and up in experience. And that was one of the things that made me feel a little bit better about the fact that, so I was actually in the sample as one of the doctors, and my performance was like solidly kind of in the middle or slightly below. And so I was like, oh, well, it's, just lack of experience, because at that point, I think I was in my second year out of residency. So I think what's useful about that is that I think it suggests, like, who are the doctors that would benefit more from the algorithm? Well, probably the less experienced ones who just haven't seen enough. But it also is kind of like an amazing thing that, and I think this is one thing that also came out of the paper, is that doctors are pretty good. Like, our training system is like pretty amazing, and doctors are pretty good at having figured out a bunch of stuff that is a really good predictor of heart attack. Like, doctors are pretty good. And one of the things that we found in the study is that if you take a machine learning algorithm and you just constrain it to use a pretty small number of variables, but otherwise it's like a good machine learning algorithm, it's just constrained, that actually looks a lot like what doctors are currently doing. And the reason that the full machine learning algorithm does so much better is just because it can use a bunch more information than any doctor can hold in his or her head. So doctors are pretty close to an optimal, but simple machine learning algorithm. But the gains come from the fact that the algorithm can hold 4,000 variables in its head, not 40.
Thank you, Ziad. And I think that speaks to the point that, ultimately, as we see these algorithms implemented, we're going to have to study not just the validation performance of these algorithms, but their interaction with different populations of users over time, and design the mechanisms for feeding back that information. And the process is ever changing and never ending. And I think has always been the case, but just the paradigm of clinical trials that forever dictate FDA approvals has misled us into thinking that any science was ever final. But of course, it's always a process of evolution. I think we're at time, but I would like to really thank Latrice, Maya, Pranav, and Ziad for their expertise and their illuminating insights to Maya and the audience's questions. And thank you again all for coming, and I hope you enjoy the rest of the conference.
Thank you.
Thank you.
Thanks, Dan.
All right. Hey, everybody.
Why is my camera so close? What's happening?
I think you need to increase the resolution in settings. I had the same cutout, but when we go to settings and put it at, I think, 1080p, it sort of zooms out.
Okay.
Wait, mirror my.
Cool.
I don't know how to.
Hey.
Low definition. There. Better.
There we go.
Frightening.
Can everybody hear everyone? I hear each of you.
Yes.
Yep.
Fantastic. This is great. So just for those of us, or for those of you who are joining us on our panel today, letting everyone know we changed the order. The speaker that was previous will be coming on after this. And so we're going to proceed with our panel. I really have been, it's a delight to have you all on here today. And I want to make sure that just from our chat, if everybody is aware of we're live now. Okay. Cool. All right. So thank you all for being with us today. We have the session 2, finding the missing pieces, right? I think that one thing that we all have in common here is we understand that data itself can sometimes be incomplete or biased because of the things that we're not capturing, right? And I wanted to give each of you an opportunity to basically give our viewers, our listeners, our participants a chance to get to know who you are. I usually will say try to keep your introductions under a minute. That way we can be as efficient as possible in our discussion. Cool? Excellent. I'm going to start with Mitch. Mitch is I think I'm familiar with Mitch a little bit. So how's it going, Mitch?
It's great. Thanks. Happy to be here. My name is Mitchell and I use he and him pronouns. I'm an assistant professor in the Department of Medicine in the Division of Nephrology at Stanford and also in the Department of Epidemiology and Population Health. I am primarily an LGBTQ plus or sexual and gender minority health disparities researcher and work with a variety of programs, both a large national longitudinal study that I co-direct as well as the National Institutes of Health's All of Us research program, which is part of the Precision Medicine Initiative to enroll 1 million diverse people from across the country and collect a variety of data types. Very happy to be here.
That's major. Thank you for joining us today. Maria, how are you doing?
I'm good. Thanks for having me. Now that I've got my camera sorted out, I'm great.
Yeah, you look fabulous.
So yeah, thanks for having me. So I'm Maria Raven. I'm a professor and vice chair in the Department of Emergency Medicine over at UCSF. But before I was those things, I've always been a health services researcher and practicing emergency medicine physician. And my research is really focused on frequent users of the healthcare system, ED-based interventions related to people's social needs that affect their health, with a big emphasis on individuals that have substance use disorders, severe mental illness, and are experiencing homelessness. And so I'm on faculty at the UCSF Benioff Housing and Homelessness Initiative, and also co-direct our section on social emergency medicine within the Department of Emergency Medicine at UCSF. And I work a lot with integrated data sets that try to use data points that aren't just connected to healthcare utilizations, but are also to people's social needs.
Excellent. Thank you so much for joining us today. Marinka, how are you doing?
Hi, everyone. I'm really excited to be here on the panel with you all. My name is Marinka Zitnik. I'm an assistant professor of biomedical informatics at Harvard and Harvard Data Science. My research group investigates machine learning with a particular focus on ways that allow us to learn and reason over complex interconnected systems or networks and graphs. And then we are using these models that we're developing based on graph neural networks and broadly representation learning in order to partner with clinical researchers and biomedical researchers to produce predictions that are not only accurate, but also are interpretable and actionable, meaning that they can lend themselves more readily to downstream experiments in the laboratory. And among the areas that we are particularly interested in include the broad range of therapeutic science across stages of discovery, from early stage of discovery to late stages of discovery, and then post-marketing, surveillance, safety monitoring, and drug repurposing, with the goal of trying to identify what are promising therapeutic opportunities for different patient groups and patient populations, including rare disease patients that have very few treatment options available.
I love it. I love it. I'm going to go ahead and bring in Sharath. How you doing?
Hey, thanks for having me here. It's an honor to be on this panel. So I'm Sharath Guntuku. I'm a computer scientist by training. I'm an assistant professor at the University of Pennsylvania. I use large-scale multimodal data coming from text, images, and sensors to basically understand questions pertaining to both individual health and also community-level health. So the goal of this research is to basically supplement clinical diagnosis and also to facilitate early and personalized interventions. I also closely work with the Penn Medicine Center for Digital Health, and also the Leonardo Davis Institute for Health Economics.
That's really cool. That's really cool. I am going to finish off with Andrew. What's going on?
How you doing, Italo? Good to see you. Good to see everyone. Thank you so much for having me. It's really an honor to be here. My name is Andrew Marshall. I actually also have a background in computer science. I was a software engineer for a little while before I joined Italo in med school at Meharry a long time ago. I am now double boarded in emergency medicine and clinical informatics. And I think at one point, Marinka was one of my lecturers in the bioinformatics program at Harvard Med School. My research currently focuses around using innovative technologies within the emergency department and within the hospital to kind of engage different patients, and also like kind of reaching into a little bit into the predictive analytics space as well.
Man, you all are some heavy hitters. This is exciting for our viewers. And so I'm going to just go ahead and jump right into this. And I want it to feel kind of like a conversation, especially because this is stuff that is often not covered in medical curriculum. And the folks who are joining us today are coming from a variety of different spaces. So I'll start with Mitch. Now, you once said that we don't do research on LGBTQ patients. We do it with them. Do you feel that there is a concept of inclusion, or rather research in general is inclusive in this space?
Sure. Yeah. So So I think, we take a kind of maybe a different approach than a lot of traditional academic research, which sometimes it's probably been best described for global health research with the term of a parachuting or a helicoptering researcher that comes into a community, uses that community, and then leaves, never for that result or that impact to be disseminated back to the community members, or for them to even know the results of a particular research study. And that doesn't just have to happen in global health. It actually happens with many underserved communities or communities that have been underrepresented in biomedical research as well. And so whether that's LGBTQ plus people, or people who are experiencing homelessness, or many other groups. And so we take I think the really important approach here is to think about community engagement when conducting research with various communities, those that have been excluded or minoritized, or nearly every underserved group or underrepresented group in research has had some horrible transgression against them by the scientific or medical community that lasts forever. And part of that, in my particular community is the HIV epidemic, and how that was ignored by science, ignored by the federal government. We had a president who couldn't even say the words HIV or AIDS at that time. Folks were ignored by the medical system and, literally left to die on the sidewalks. And so in order to rebuild that trust is a hard thing, and that takes a fair amount of community engagement. And so one approach that both I try to take in our research, but also that the federal government is taking now in various large-scale projects, and that even globally there's increased engagement of participants, is really making sure that there's a way to involve research participants at every step of the research process. So that's not academic medicine deciding the best research questions to ask. That's actually the research participants figuring that out. Then how do we recruit people? What are the research actual procedures that are done? Is this all done in a welcoming, affirming, inclusive way? And it doesn't really just end there. The data gets collected, it gets analyzed, and then we bring that data actually back to participants and say, are we interpreting these data correctly? Are these exactly what the community needs? And is this a correct interpretation? And then do we actually bring those data back to the community in a way that they can understand it? And that's not a journal article that you have to pay $50 to access for 30 days. That's actually a community-friendly summary of that paper that's written in anywhere from 7th to 9th grade reading level, that folks can really understand the key points of that paper. That might be social media images that can be shared on social media that have a key single point of that work. It might be a session, an interactive session, kind of like this, where there can be experts in that particular topic that discuss some of the key findings of the paper in real time with members of the community in various forums, whether that's in person or digital. And importantly, it's making sure that community members and participants see themselves as co-owners of a particular research project, and that they are as important as the academic researchers. And so thinking about community partner organizations, nonprofit organizations, community-based organizations that you may be able to partner with and engage to show that you're actually committed to involving communities that have really been underserved and underrepresented in the past. That's one, but there's many other options as well.
No, I believe it. I just really love this concept of restorative justice in the bioinformatics space, specifically because you're talking to marginalized communities and trying to bring them not just at the table, but set the table. Hopefully everything is coming through clear.
Yeah.
Perfect. All right. I'm gonna no, because with the technology, I want to make sure that everybody's on. So I want to quickly pivot to Sharath, right? So it sounds like you do work that basically focuses on building these predictive models, right, for uncovering insight into health outcomes and psychological states of individuals, right? Where do you look for information, and how do you link that to their medical care?
So I'll preface by saying that we use social media a lot. So that's one of the big sources of our data which we collect from. For instance, a lot of studies indicate that most people use social media for over 2 hours a day. And if you're under 25, you sort of hit the jackpot. You're over 3 hours a day, right? And when you use social media, we post a lot of cat photos, yeah. And then we also post a lot of how are we feeling in the moment sort of statuses, right? So there's a lot of online support seeking and sharing and so on. So what we found is beyond the social desirability bias that is ingrained in a lot of social media exchanges, these platforms, or the data in these platforms, have a lot of signal related to health. So for instance, at Penn, this is, again, a work led by Dr. Raina Merchant, who's an emergency physician at Penn Center for Digital Health. This is a collaboration with her. We've tried to ask patients in the ER if they'll be willing to share their social media data and also their electronic health records. And surprisingly, we found that over 30% of the patients we approached say yes. And we find that people who say yes, of them, about 80%, or I think 85% of them have usable social media data. So now you can think of 4 to 5 years of Facebook data across retrospective data, and also this similar electronic health records, right? So now we've used this a combination of these two data sources to answer or rather understand a couple of different problems. I'll try and highlight a couple of them. So one was we tried to see if Facebook posts alone can forecast if if a person will be depressed, say 6 months before their official diagnosis or 3 months before their official diagnosis. And surprisingly, a machine learning model that is trained just on language from patient social media posts does about, I think, 0.7, 0.75 AUC, right? So this is not a diagnostic metric, but at the same time, it has a lot of signal, right? And similarly, we saw that we tried to see if Facebook posts alone can forecast whether a person will be in the ED 2 months later, right? Or if they'll have an inpatient visit 2 months later. And surprisingly, the AUCs are again at 0.68, 0.7. And it's not just the predictive utility of these models, but it also lets us understand what's happening, right? So what are the dynamics, or what the behavioral dynamics that are unfolding as people are living their lives? So for instance, in one of the ongoing works, we found that individuals who are depressed, we usually don't say that we're depressed online. But the two big markers of depression are the words lonely and alone, right? And we usually never, rather, a lot of survey instruments that measure in depression don't really ask about loneliness, right? So we are able to get a nuanced symptomology of how these diseases manifest online. And beyond prediction, we're also able to understand, get better insight into how these diseases unfold. And also, this line of work sort of has a lot of ethical challenges and considerations, right? So a lot of open questions on how you'd want to collect data, what is the data ownership, what does the privacy look like, right? But at the same time, we found that social media sort of offers a great low-cost resource to sort of track individuals' health over time. And when we use computational techniques, we can actually use these models that are built on individuals, we can take them to communities, right? So if we say train a model that estimates loneliness on individuals, we can do some domain adaptation and then apply that on Twitter from counties in the US. And we found this to be a lot of value, especially after COVID-19 hit during the initial few months when mental health sort of spiked. And we were able to sort of use Twitter and our models to forecast county level mental health estimates, which departments of health at Washington and also Pennsylvania sort of used in their weekly reports. So yep, so I think the short answer is social media is where we look for this, I think, collateral information, if you will.
No, that's very innovative, and I think just kind of following those markers to me sounds like an approach that can be applied very broadly, especially when we start to to expand that thinking a little bit. And so I'm glad that you're doing that work. I'm going to go ahead and ask Maria. So you said a couple of things as a public health guy. Something you said really stood out to me. Your focus on these different social and structural drivers of health, and really looking at housing and substance use, the patterns and how it interfaces with the emergency department. So I kind of want to ask you, like, it sounds like you're using this information, but what are some of the ways that you've seen where not including these social or structural drivers of health negatively impact patient care, and really how you're using this information in your research?
Yeah, great questions. Well, so I'll give you a couple of really concrete examples, I guess, for people that, I mean, I think to us in the emergency department probably seem very intuitive, but to other people might not seem as intuitive. So for example, if you come into the emergency department and you have diabetes that's been very difficult to control, and you are living in a shelter because you just lost your apartment, you probably don't have any way to refrigerate your insulin. And if you don't know what someone's housing situation is, then you can't take that into account when you're trying to make a plan for that person when they're about to leave the emergency department. You know, along the same lines, you know, if you're not asking people about their substance use disorder, then you're not understanding the way that, you know, 20% almost, quote from the NIAAA, which is an NIH agency focused on alcohol use disorder, about 20% of emergency departments are somehow impacted by alcohol use disorder, whether it's trauma, whether it's, end-stage liver disease, whether it's a fall and you're hypercoagulable and you bleed, whether you're in alcohol withdrawal requiring admission to the ICU. If you're not asking about these things, then you're not getting at fundamental aspects of the way that we need to think about people's overall health. And I think, you probably know this, Italo, but research shows that less than 10% of an individual's health is actually impacted by what we do in the healthcare system. So, you can think if you're a doctor in the ED, like you're out there and you're saving lives, you're impacting people's health, even if you're in the clinic, whatever. The reality is, without understanding what people are experiencing outside of the healthcare system, which generally can be a very black box to physicians, unless you really take the time and effort, which can be a challenging thing to do, you have no idea what's actually going on for someone. And I think a lot of that I realized when I was in residency, and I kept seeing these people cycle back into the emergency department, and, we would give them a sandwich, or we would give them an treatment for their asthma, or, we would admit them for their alcohol use disorder. And then they would literally be back sometimes the same day, sometimes 3 days later. And it's like, what's happening? Like, we're not doing something right here. Like, we're not taking advantage of the fact that this person is coming to us in the emergency department to actually do anything useful. And so that's really where I started to think about, well, what can we do from the ED, and other points in the healthcare system, or what can we look at that is impacting people's use of the healthcare system that we can do to make that situation for that person a little bit better. And it turns out, it's rarely prescribing a medication. It's rarely, ordering a CAT scan. It's usually something that's really much sort of simpler, but in a lot of ways much more complex and difficult to actually carry out, because the reality is, we don't have enough housing. We don't have enough substance use treatment beds in the community. We don't have enough locked inpatient unit beds. We don't have a lot of these things. We don't have enough social support for people. I mean, someone mentioned loneliness. It's a horrible problem for people, and loneliness has a huge impact on people's health and their ability to make connections. And these are things that really do play a huge role, but I think we often feel powerless in the medical field to really do anything about. So the more we can integrate all these data points into the research that we do by for example, we have data sets that we work with that are big data dumps of people's housing, of their use of substance use services, mental health services outside of the health system. If you can integrate things like employment data, even I know that there are people doing things with, like, did people's power get turned off? All these different things, you're going to find connections. We just integrated a database with people's use of the criminal justice system, and it's shocking, the things that we're finding. It's not shocking, actually. It's completely obvious, but it's just, it hasn't necessarily been shown because people haven't traditionally linked data sets with healthcare data. And the reality is, I think everyone on this panel realizes, and is doing it, it makes a lot of sense.
No, you hit the nail on the head. This is a sophisticated type of blind spotting that's happening. Everybody's finding these gaps, and I'm just excited to hear about the different ways. Obviously, I'm passionate about it. For someone in the audience or in the comments, they asked who I was. I realized I didn't say who I was in general. I kind of just wanted to get to the conversation selfishly. I am Italo Brown, emergency physician at Stanford. I also am a social emergency, a recent grad for the fellowship at Stanford. And I do work in barbershops, essentially leveraging the cultural capital of barbershops in the Black community to address the health and wellness of Black men and boys. I've been doing that.
Case in point, right? There you go.
Right. So it's really about understanding the community and being able to find those blind spots where you have disparities existing because our lack of ability to solve those problems. And what you all are bringing to the forefront is using informatics as a way to kind of not just elucidate that, but also to create an avenue for solutions. I've been doing this since med school with my buddy Drew. So I wanted to give Drew a nice opportunity to talk about it, because Now, when we were in med school, you were always talking about, man, technology is the way. We need to go. We need to use our technology to drive these solutions. And I was like, oh, no, man, I just want to sit in a barbershop and listen to the problems, do these listening sessions. We worked on creating an innovation center at our historically Black medical college that was largely driven by Drew. But in doing that, you realize the need for solutions for these equity gaps. Whether we're talking like stroke care or anything in emergency medicine, these equity gaps exist. So what are some of the ways that you've been able to pursue this, or rather move the needle on this problem through your work?
Yeah, well, thanks for the great segue. I'm going to come back to some of what you said a little bit later, but I want to give a little bit of background. So I think, like, as a clinical informatician, I think of myself as about 50% researcher, 50% implementer. And so equity and technology they're both kind of like really broad concepts. As like an ER doc, I think a lot about clinical outcomes. I think a lot about efficiency. And as a clinical informatician, I think about how technological interventions can improve healthcare delivery and patient outcomes. To me, this kind of naturally includes thinking about, patient populations that, obviously receive inequitable care. So I want to start by saying the obvious. There's no single solution, magic bullet, or anything like that that's going to address all health equity gaps. And I want to also say that not all tech projects in healthcare kind of set out to solve health equity problems. But every tech project that's implemented in healthcare will have an effect on equity. And so it's the conscious acknowledgement of the equity issues within the tools that we use that will help us address and kind of close gaps. So I want to share with you guys a couple projects that I'm working on. And it may seem like I'm kind of all over the place, but I hope to bring these all together with like a common theme. And so, Italo, you quickly mentioned stroke care. So, here at the Brigham, I served as the chair of social justice for the Office of Ideas, and Ideas stands for inclusion, diversity, equity, and social justice. And one of the projects we sponsored that was done by one of our fantastic residents in the first year was surrounding using videos and Zoom classes to educate high schoolers in underserved neighborhoods on how to recognize the signs of stroke. So this is really simple technological intervention, right? We use videos, we use Zoom calls, stuff that we're all pretty used to right now. But not only did it help close health education gaps, but it taught students how to advocate in their community for their loved ones and, advocate when to be taken to stroke centers when appropriate. So those of us that recognize the imbalance of, distribution of like kind of high quality healthcare centers, recognize that, underserved neighborhoods may be, they have some structural inequities that go way back, people in those neighborhoods kind of have to recognize and overcome. So this may help overcome some of those structural inequities. I spent a lot of time at the Brigham working with companies as well. So one of the companies I've been working with recently is e-ink. And e-ink has this clever technology that's pretty novel to emergency department settings. And we wanted to figure out how to use it to engage patients. And so, working with this supplier, we were able to develop digital whiteboards that help track patients, tell patients where they are in their stay, when they're in the rooms. They provide contextual clinical information to help address like anxiety and communication regarding like wait times, what's going on, whether they're being admitted and all that stuff. So the interesting results were that, this innovation kind of improved satisfaction. These patients felt more informed about their stay. They felt more enabled to kind of like ask questions. They felt, empowered to know what to do after they were discharged. It addresses health literacy gaps because, we have lots of technologies, lots of portals the patient can log onto and kind of see, what's going on with their healthcare, but they might not have that information in context. It also addresses tech literacy gaps. So, patients here have access to Patient Gateway, but, they have to make a login. They have to download an app. They have to know how to navigate the app properly. And so if we're presenting that information in the way that's very digestible to them the minute they come in, it kind of addresses those tech literacy gaps. And then we're addressing the people that can't afford tech, right? People who don't come into the emergency department with iPads, that don't come in with, their own smartphones and stuff like that. We're providing the device for them so that they can interact with it there, like kind of live, during their visit. And so, most importantly, now that I'm, kind of working with these, companies doing research, we can kind of talk a little bit about how we can provide these information this information to patients that traditionally aren't really thought about. Patients that experience the emergency department in different languages. This is a population that we've never successfully been able to reach with traditional measures of satisfaction like Press-Ganey and all that good stuff. And so, we're also doing some work with predictive algorithms. So, many of you are familiar, if you work in a hospital setting, with home hospital programs. And so those home hospital programs, right now involve a manual selection process. And so we're building rules-based algorithms within Epic and, the EHRs to kind of select patients that may be suitable candidates to go to home hospital. And home hospital has been shown to be kind of we've shown the ability to provide inpatient level care for patients, even in a non-inpatient setting, so in their own homes. And so, while we're in the process of implementing right now and scaling the program, we have an opportunity to look at the equity of the tool. And the equity of this tool may reflect the equity of the program, because we know that, human biases are often reproduced in the programs and the tools that we build. And so, if you think carefully about home hospital programs and you're excluding people based on neighborhoods, you're excluding people based on social situations at home, that thinking carefully about kind of how to address these before we scale it up, before it becomes a big equity issue, and we're excluding whole groups of people, is really important, right? Because it's better to catch it now before this becomes implemented at a large level. And there's so much more I could talk about. We're thinking about how to train patients while they're in the hospital on how to use their devices at home, so that patients that have transportation issues, patients that may experience disparities in where they live, rural patients, and patients that may have tech literacy, can engage with telehealth follow-ups, which are kind of becoming standard in our kind of world as we live. So I'm going to kind of stop here and say all of these interventions, they're all tied together because they give us an opportunity to connect with patients that we may have otherwise missed, and hopefully engage with them in their own healthcare. And the byproduct of that inclusion is not only better outcomes for our patients, but better data for us to build with.
Man, fantastic work, fantastic. I'm going to Marinka. Hey, so I had a couple of questions, right? I mean, we've heard a little bit about these equity issues. We heard about how social media is being drawn forward. We've heard a little bit about social and structural drivers of health. Now, your research, pretty much from what I understand, is about developing methods to reason over these interconnected data networks, right? What I want to know is, what are some of the ways that connecting data has led to this greater knowledge or understanding, or maybe even wisdom than we would have had if this was not done by itself, if you had not been able to kind of identify these methods early?
Yeah, thank you, Italo, for this question. I think it's very important to consider that many of the problems that were mentioned by speakers earlier are so complex that there is no single data set that would have the totality of information considered within it that could fully help us understand the complexity of that particular problem that we're studying. And so that has important implications for the kind of underlying methodology, in particular machine learning methodology, that we might want to be considering when analyzing those data sets. And this is mainly due to a broad range of challenges, out of which I would like to highlight three, that very often we need to think about data that span multiple scales. So that involves thinking about the level of genomics, and even within genomic context, we might want to think of cells and tissues and cell organ systems that are affected in kind of different scales. But even individual is then placed within a particular environment and a kind of local community, and that kind of context then require us to have methods that could bring together these different scales of data, going from the level of individual molecules to the level of tissues, organs, human body, and community within that individual is embedded. And so that is quite challenging from the methodological standpoint, because it does not necessarily fit into more classic view of machine learning, where we typically think of fully observed fixed size data matrices or tabular data formats that fit into ML models. And so the second type of problem, a challenge that I see here for methodological development, is that it's just incredible to see what kind of biases and confounding we can see in all these data sets, right? It goes from investigational bias in genomics data. There is actually interesting to see that the level of understanding of functions of certain genes highly correlates with funding cycles of NIH. And if you think of it like that, it's not surprising, because the more resources are put into the design and study of certain type of molecular functions and biological pathways, that would mean that there are parts of the genome space that are much more studied than others, of which you know more than others. And so that kind of investigational bias can then percolate up the number and go to the higher level of scales, where we know that due to biological variation or limitations of existing experimental platforms, part of biology is harder to study and probe. So we have less data available for that. And as soon as we go into this environmental or social context, various kinds of issues related to the way who are the nature and diversity of participants included in clinical trial studies would then be more or less understood in terms of their effects for novel therapies that are being designed and so on. So that confounding is also hard to challenge. And finally, of course, these data are very heterogeneous. They go from experimental readouts, self-reported observations, curated annotations, and because of all that, I think that it requires, because of all these challenges, we need to very thoughtfully and carefully think about the proper ways to integrate the data that are not just about stitching multiple data points together. And so why is that helpful? That's helpful because ultimately I think that being able to ground models in prior knowledge in the biological context of a problem that we are thinking about can help us get models that are more robust, that generalize across patient populations, meaning that their predictive performance would be high when we stratify performance of a predictive model by specific patient groups that we want to, that we expect the algorithm will see when it's being implemented in practice. And they, in a way, they can stimulate and lead to novel biological or medical insights, which ultimately can translate to knowledge and wisdom. So very briefly, let me mention a few examples of that kind. So one of the recent work that we were involved in was concerned with understanding how does the use of prescribed medications and associated adverse events change in the times where we are faced with a public health emergency, like a pandemic or a fire or some other kind of emergency. And so when we look at that, the kind of the adherence to medication use and the experience of patients in obtaining unwanted adverse events associated with those medications without considering the specific context of individual patients, then we won't really see the precise signal that only becomes clear when we take into consideration the geography of that patient. What are the proximity to relevant healthcare systems for individual patient? What is the social, demographic, and economic status of that patient? And so that kind of more precise characterization is what is enabled in many ways by network graph-based view, where we can bring these different modes of information together and then be able to cluster, stratify, and predict for individuals at the individual level, rather than at the kind of global population level manner. And finally, in the context, and I will conclude with this example. So the one of challenges that my group is particularly interested in recently resolves around patients that are very hard to diagnose and treat because they might either have an unusual representation of understood disease, or they might suffer from a rare disease that a clinician might not have seen in patients many times or not at all throughout their career. So that's really challenging because those kinds of patients are a very underserved population. There is very little incentive from pharmaceutical industry to be developing treatments for populations for whom that are typically very small. And it's very challenging for the medical community to be able to even diagnose those patients. And on average, they need to go to over 7 specialists over multiple years of time to get a proper diagnosis. And so what we are doing in the group is developing and implementing some of the knowledge-grounded methods with the purpose of being able to take the context of an individual patient, their genomic data, their deep phenotypic information, and really in a kind of hyper-individualized manner, be able to prioritize possible diagnosis for that patient, and then identify what might be the therapeutic modality that's already consists in the form of already available drugs for that individual patient. And so what's very interesting to see is how many low-hanging fruits are there. As soon as we have some kind of flexible and robust methods, it's possible to really have such an important, strong impact on the life of patients. And we're very fortunate to be able to then partner with various patient communities who have put in so much efforts to build their own databases. And they're kind of leading their own research in their specific disease areas that are underserved by medical community. And then partnering with those communities, and in our case also with the Undiagnosed Diseases Network, that is a nationwide initiative for patients of the type, is really kind of, to me, an indication of how much models, when developed thoughtfully and implemented very carefully in partnership with then the end users of those models, can help understand and the complexity of a given disease, identify possible or nominate potential treatments, and be able to provide recommendations that could fit into some actionable insights for a particular individual rather than entire individual population at once.
I got you. I'm going to slide to these questions. I have a couple of them in the comments section, but thank you. Mitch, this question, I thought about it while we were talking, while I was listening earlier, but I'm glad that it was also offered. It says, what are some things you've, like some specific insights that you've learned from the Pride community when it comes to whether, I think this one, oh, there it goes. Perfect. It popped up. Boom. Look at the magic.
Sure. That we wouldn't have been possible through other means. Yeah. So I think, because we had to take this very community engaged approach, and to expand on that a little bit, that involves, in our case, we have 15 LGBTQ plus people from across the country who are diverse in kind of every way possible, that we pay every year as advisors to our study and to our work. They meet with us monthly for 2 hours at a time, so it's not an insignificant commitment. And we also have a set of what we call the PrideNet ambassadors, which are a group of spokespeople that are well connected to a variety of communities. And so I think, we actually started our work with Pride by creating, using an iPhone app actually to really define and gather health priorities and research questions from the community. And so I would say agenda setting is something that we definitely would learned that way, and would have been, I think, harder to do through other means. Probably would have been possible, but would have been more difficult. And we've also done community listening sessions where our staff actually goes to various places across the country, meets with people in real time, face to face, gives them food, and we talk about the barriers to participation in research. And that allows us to then hone and reflect a little bit on our engagement strategies and recruitment strategies, and ways that we keep people, that we deliver value to people, and figure out ways to change that. And then now, because in the Pride study we have now over 25,000 participants, and data that's been collected now in its sixth year of data collection, we have more data points than we within our own group are going to be able to ever analyze and research question, and hundreds or thousands of research questions. So we've created an ancillary study process where we partner with either academic researchers or community-based researchers to answer LGBTQ related questions. And in addition to our science committee reviewing these proposals, we have a participant group that also reviews these proposals, and they're given equal weight in the decision of whether or not an ancillary study proceeds or not. And so what we have found is that the perspective of typically academic scientists can be very drastically different than community members. And that includes both the importance of a particular study or whether or not a study might actually be doing harm to the community broadly. So we, are very fortunate to have this 50-50 partnership with a set of community members who will say, you know what, that's an interesting question. However, we're concerned that it's going to actually result in harm to the community in ways X, Y, and Z. And so this study needs to be modified in order to not effectively worsen the trust which you've worked to build for many, many years. And so that might be something to be careful of. So I think it's really been important for identifying some maybe third rails that we were close to hitting, while simultaneously just making things more welcoming and affirming to our community so that they continue to be active and engaged participants.
Thank you. Thank you. Maria, there is a question that just popped up, and it was actually something that I was considering. We can get that on the screen, and I'd love to give you an opportunity to kind of like take this one. It's a slow pitch, in my opinion, based upon your expertise, but I think that some of our listeners are coming from different spaces and want to know the insights that you've gained from your work.
Oh, just insights that I've gained?
Yeah,
Oh, yeah, sure. Well, so I think the things that I've realized, if I had to give a couple takeaways, are that we make a lot of assumptions about people when they come in to seek healthcare, and they're based on sort of heuristics, right? Like you have certain visions of what you think a person in a specific situation might present as or look like. And I think one of the big things is, unless you ask people about things like their housing status, if they're at risk for substance use disorder, all those kinds of things, it's really hard to actually know. So if you don't ask, you don't have the information. And that's one of the problems in using healthcare data alone, is that as physicians, we're actually not very good at asking people. I think sometimes we feel awkward, not sure how to ask a specific question, like about people's housing status, when in fact you can just ask something like, where did you stay last night? To anybody, and they will probably tell you and be fine with telling you. And so the problem that creates when we don't ask is that we don't have data on all of these things. We don't have good data. And so we need to ask a lot more. We need to have more systematic ways to gather these data on people in the healthcare setting. I mean, I love Mitch's concept of kind of this idea of creating a registry, but like more within healthcare, like how do we get all this information when there's so much that we're asked to do? But that's why it's so important to try to combine data from many different sources in order to really get the picture of the whole person, because that's really what a lot of the time we are lacking. So I think that's something that really needs to be a future focus of the work that we do.
Thank you. Thank you. We're coming to the close of our section, and I know that, hey, Maxine, I'm so glad that we were able to get you fully up and running. And I just want to take an opportunity to say to everyone that's part of this panel, like, the work you're doing is incredibly important to us. I know that as someone who operates in social emergency medicine, like seeing the different spheres from not just our research sphere and our informatics sphere, but also seeing how the outcomes related to vulnerable communities are being woven into that. It's exciting, right? Like, it's exciting to know that data can pretty much be used in a way for us to answer some of these questions that I would say over the last 50, 60 years, we've had some inkling of and slowly have developed more understanding, but now it feels very targeted. It feels very tailored. And on top of that, I think the opportunities that exist specifically for learners are starting to grow. So people who are ambitious and want to be able to engage people in a way that hasn't been used before, because technology has changed so much, that's exciting. And I keep saying this. I told someone a little earlier that our clinicians are being trained to be the physicians of tomorrow. And you can't be those physicians without understanding these tools and being able to answer these questions in a way and think about them in a way that we haven't thought about them before. And you all are doing it in real time. So that's really encouraging. I'm going to go ahead and take the opportunity to thank each and every last one of you for joining today. For those who are in the audience and you have questions, there are going to be ways for you to reach each person here on the panel if you have specific questions or you're interested in engaging them, or maybe even seeing if there's opportunities for collaboration. I know that we love that word across academic spaces. So without further ado, I'm going to pass this over to Maxine for her presentation. Thanks again. Listen, this is very exciting to me, y'all. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you.
Thanks.
All right.
Awesome. So actually, I think that because of the technical difficulties, we've sort of had to substitute out. So I think that I'm correct in that we are going to probably just do a recording of the talk to be shared a wee bit later. But can someone just confirm that on the chat? But I think that because of overrunning, we are just going to share a wee recording later. Let me just double check that's the case.
Yeah, that's the case. Unfortunately, because of technical difficulties, Maxine didn't get a chance to present, but we will be uploading a recording of her slides and speech to our website so everyone can see that.
Awesome. Also, maybe I can just do a wee bit of a pitch. So if you care about genetics, if you care about how to implement some of the things that the previous panel, this panel, have been talking about, but in a kind of live government program. So, it's not for papers, it's for real patients and national scale, and just some of the frameworks and the problems that we've been working through and how we kind of made these very, very tricky decisions about how we prioritize people in what way and how, and what metrics we want to use, then listen to the recording of my talk. So yeah, there's my shameless little plug, and I'm so sorry to the organizers for despite the fact having wonderful Wi-Fi, it just not putting through for this. So I'm really sorry about that.
Thank you so much.
No worries. Thank you. Bye.
Hi, thanks for joining everybody. My name's Andrew Yeland. I'm one of the founders and software engineer at Diagonal. We're a UK-based company where we build tools to help people understand urban geospatial data problems. And we often end up dealing with problems that touch upon public health and equity. Although previously I was more deeply involved in healthcare technology at DeepMind Health. But I wanted to talk this evening for me in London about how technology can support privacy and its implication for the type of data that we get to work with in healthcare. And I'm going to start by setting the scene with a couple of stories about data privacy that I'm sure some of you have heard before, but then progress on and start to consider whether or not there are gaps that exist in the software world due to the biases in the industry that we work in. So just to ease into the topic, I thought I'd talk a little bit about the classic case of Latanya Sweeney, the professor now at Harvard and founder of the Data Justice Lab, who early on in her career analyzed census data to determine that 87% of the people in the US are uniquely identified by their zip code, date of birth, and sex. And so when Massachusetts State Agency started releasing anonymized hospital visit records to researchers containing those same attributes, she was obviously interested and used those results to re-identify the anonymized records of the then governor of Massachusetts, William Weld, sending those records to his office. Sorry, it's a theater. And that's probably the most health relevant of a long series of attacks on privacy in data for research. One of my favorites is reverse engineering the identity of people who ride in taxis based on research data from the New York Department of Transport, and possibly reverse engineering which films people watch on Netflix based on their recommendations data sets, largely because that was so unlikely that that was possible. There were no personal identifiable data or even names of films in that data set. It was just raw numbers, but people were able to reverse engineer people's viewing habits from it by comparing against IMDb. And I think that's what most of these attacks depend on. They depend on relatively convoluted comparisons of research data with external auxiliary data sources. And I think previously, certainly I found it difficult to think about that being a realistic threat model, given it takes so much effort to do this. But, you know, we've just spent the last decade pushing the cause of deep learning, which does a fantastic job of combining disparate data sources in an unsupervised manner. And I do wonder whether or not such a system, you would even notice this. What you see as an increase in the predictive power of your model is actually re-identification behind the scenes. Maybe that's good, maybe it's bad, it depends on the context, but the fact that it is not explicit, I think, bothers me. But I think to tie this back to the point of the conference today, I think the real question there is, how does that impact the data we work with? Well, all healthcare data is incredibly sensitive, and so the ability to work with that data depends on maintaining a social license to work with it. And each of these trust events chip away at the foundations of that social license, potentially leading to it collapsing and ultimately halting research and causing real clinical harm. So I think the cause of privacy protection is a significant future and current threat towards medical research. But luckily, there's a bunch of interesting technologies that could potentially help us out in this case. And so I'd like to talk about a few and then possibly where I think that their limits are. I think the earliest flavor, which is quite easy to understand, is a technique developed by economist Stanley Warner back in 1965 called randomized response. So Stanley Warner was an economist interested in computing estimates of how the population felt about certain sensitive topics. For example, particularly relevant to the US at the moment, have you ever had an abortion would be an example of such a question, where it might be useful for research purposes to compute an estimate of that answer at a population level, but the actual underlying answers are obviously sensitive. So his relatively understandable technique when asking people to answer that question is to get them to flip a coin first. If the coin says heads, you say, yes, I have, which is the sensitive answer. If the coin is tails, you answer truthfully. And the upshot of that is that for any one individual, the most likely reason why they have given a sensitive and potentially incriminating answer is because the coin told them to do it. And yet when you start to aggregate those values up at a population level, you know that there's going to be half of the answers are going to be determined by the coin toss. And so from that, you can reverse calculate that the number of no's is half what you expect, and the number of yes is simply the remainder. So you can compute roughly accurate population estimates for a sensitive question without ever actually being able to know the true answer for any one individual. And when you think about it, what this is actually doing is adding noise to your data. The coin toss is adding a component of randomness that protects the underlying data. This was very early work back in 1965, but the concept was radically advanced back in 2006 by Cynthia DeWalk and others in a concept called differential privacy, which is provides quite a strong mathematical underpinning to this idea of adding noise to data deliberately to mask the effects of any one individual on values computed with that data set. So it is rigorously mathematical. It's applicable to all modern data analysis techniques, but it has a few problems. The maths behind it is relatively hard. We know, for example, for simple cases of adding up numbers, that if you sample noise from a Laplacian distribution, it's optimal in terms of protecting the data while maintaining accuracy. But when you start stepping away from that into more complicated real-world problems, we don't yet have the reusable frameworks yet. But certainly to me, I think the biggest problem is it sets up this concept of privacy versus accuracy. The more noise you add to a system, the more you protect an individual's privacy, because the harder it is to understand the impact of any one individual at that on that data set, even when comparing against auxiliary data sources. But obviously, the corollary is the less reliable your analyses are. And so that is in the mathematical model is encoded as a value epsilon. And so the big question is, how do you determine the epsilon? I think if you look at the research and indeed in how people feel about it, the obvious answer is those kind of trade-offs need to be pushed back to the very data subjects that are represented in the data sets that you're working with. Ultimately, it's their privacy that you're concerned about. And, you know, this is a very difficult mathematical set of techniques, even for data scientists to understand, let alone to try to communicate to an average participant who shouldn't necessarily have to learn about these things. And in fact, when we've, having seen research that's attempting to do this, typically the first response from patients and study participants is like, why are you making this all so difficult? Why are you not just using my data to help other people? So as part of that, consider a separate approach given those challenges. Let's talk about encryption. We know that encryption is fantastic for keeping data secure against attackers. it's just a shame that you need to decrypt it to actually perform your analysis. If only you could keep it encrypted all the time, you could do your analysis without ever actually having to expose yourself to data, only seeing the safe results of the analysis. And indeed, that's what the field of homomorphic encryption allows you to do. It's a set of encryption technologies that allow you to perform operations on data while the data is still encrypted, and then retrieve the results post the end. Fantastic for actually protecting yourself and others from being exposed to sensitive data during an analysis. And there are some very fast and robust implementations of this technique now, for example, the Pioneer and Algamel crypto systems. The problem is that they are quite limited in what you can do with them. Pioneer, for example, you can add numbers, but you can't multiply. Algamel, you can multiply numbers that you can't add. And so obviously adapting them to a wide variety of real world analyses that typically involve both adding and multiplying at the same time can be tricky. The good news is that this is a field that's advancing rapidly, and there are increasingly schemes out there for which you can actually perform all kinds of data operations in an encrypted space. The downside is they're still around 1 million times slower than working on data in an unencrypted way. So they're too computationally expensive to apply everywhere, particularly if you're dealing with large data sets such as genomics and the like. So given these techniques are too complex, too computationally complex to apply broadly, the question is, well, how do you choose where to apply them? What's the most sensitive place to apply them to? Where is it worth that additional computational cost for the extra privacy? And now we're back to the same question that we're in differential privacy. We're having to go back to a population and try to source their opinion on quite an abstract technical problem, when certainly in the world of healthcare, they likely just want you to get on with the job of analyzing it. So don't get me wrong, the differential privacy and homomorphic encryption are both absolutely important tools and techniques, and I urge anybody working with data in this space to seriously consider using them while considering their fit to the projects that they're working with, because they're a great way to protect individuals, and possibly also, coming back to Missingness, a great way to provide an additional level of protection to individuals who would perhaps ultimately feel nervous about otherwise being part of the study. But let's consider the wider ecosystem here. Like, who is building and promoting these technologies? What I'm interested in is how did we end up in a situation where we're trying to force abstract mathematical trade-offs onto patients who want their healthcare data analyzed? And so the question is, who's building and promoting these technologies? Largely well-funded consumer tech companies. How do well-funded consumer technology companies think about their data? Well, most of them were born not that far away from Stanford, as it happens, in the counterculture movement of the late 1960s, where you have, free love, free software, self-sufficiency through tools, and fast forward to today, and that technological ideology of self-sufficiency has kind of ended up in a state of data libertarianism. Your data is yours and yours alone. You should choose who gets to do what with the data, and why. But also for these for technology companies, that's problematic because their business models require them to analyze user data en masse. And ideally without getting your explicit permission first, because if you had to go back to everybody who uses their consumer products to get permission to do the data analysis that they want, all of their progress would stop. And so differential privacy and homomorphic encryption are perfect tools in that case. They move from concrete questions about whether or not it's ethical or appropriate to use data for a particular purpose to abstract questions about how you use privacy-preserving technologies to transform identifiable data into something that you can work with without asking too many questions. It's quite interesting how easy it is to gloss over these abstract questions about how big your epsilon is or how homomorphic encryption should be used or not when you're actually talking about billions of dollars of ad revenue. The environment of working in healthcare data is very different. There is a rich tradition of involving patients through informed consent rather than through working with data about people behind the scenes. And more often, their interests are aligned between patients and the people working with data. Ultimately, they want research to happen so that they can actually benefit from the results. And finally, in medical data, sovereignty, this idea that your data is yours and yours alone, is nuanced. My data, my DNA, tells me all about my children and parents. And indeed, if my DNA came from the UK and I was sequenced as part of the NHS's programs, that's through billions of dollars of socialized healthcare investment. And so, can I alone claim sovereignty over it? So I guess my final question, which I think would be interesting to look at in the panel, is, we have tools like differential privacy, we have tools like homomorphic encryption. They came from a very different ecosystem to healthcare. And so ideally, in the healthcare space, are there tools to work with data and models of data governance that don't exist because the ecosystem who are developing tools that we use in the first place is not the ecosystem working in healthcare data? And I hope to dig into that in the panel afterwards.
Right. Hello, a warm welcome from Stanford University. I'm Mike Gisandi, and I serve as Vice Chair of Education in the Department of Emergency Medicine here at Stanford. And I'm very excited to moderate our final panel of the day, which will be future focused. We're going to touch on a number of issues such as data sovereignty, design thinking, community engaged models, and innovative ways to evaluate data sets. But we'll begin with introductions. I'll ask that each panelist introduce themselves with their institutional affiliation and a short description of their work. And we'll start with Crystal.
Yes, everyone. Thank you so much for the kind invite. My name is Dr. Crystal Sosi. I am incoming assistant professor at Arizona State University in the School of Life Sciences and co-founder of the Native Biodata Consortium. My areas are related to indigenous genomic variation and population genomics related to precision medicine and health, and also increasing health equity using new technologies in AI and ML. Thank you.
Well, thanks for being with us. David.
Hello, everyone. I'm David Jenka. I work in a lot of different places, but a lot of the work I do is at the Stanford D School, or the Institute of Design, where I both teach and work on design projects. And then I consult with a variety of different organizations, a lot of them within healthcare, thinking about healthcare design challenges. So really my work right now is at the intersection of design and healthcare and how we can kind of mix those two worlds better. Thanks for having me.
Thanks for being with us today, David. Alsir.
Yes, thank you. My name is Alsir. My background is in global health, international relations, and public administration. I work as a public health analyst for Economist Impact. We work very closely with our partners to be a catalyst for change and enable progress. We've been working on so many different topics in health tech space, such as recently we launched a Healthcare Redefined podcast that looks at digital transformations in the Asian health systems. And we're very excited to contribute to this panel as well as further knowledge and research in any way we can. So thank you for having us.
Thanks, Elsier. And Nagar?
Hello, my name is Nagar. I am a senior research scientist at Google Responsible AI team. During my PhD, I was working on larger scale machine learning models and machine learning problems. And then after my PhD for a couple of years, I was working on efficient learning using less labeled samples for learning. And then during the last couple of years, I was at Google and I was trying to have a retrospect view over the machine learning practices, specifically on data and evaluations, and the kind of practices that machine learning communities do, specifically in contexts like healthcare as well as creativity.
Okay, great. And then the audience just met you, but we're going to ask you to introduce yourself again in case they missed your initial introduction. Andrew.
Hi, I'm Andrew Eland. I'm a founder and software engineer of Diagonal, a data science company where we build tools to help people understand urban geospatial problems, often touching on public health. Previously, I built machine learning-based healthcare technology with DeepMind, and currently I sit on the board of Genomics England, which is the UK company that manages all genomic sequencing for the NHS in the UK.
Wonderful. Well, a warm welcome to you all. Thank you for sharing your time and expertise with us. I'm really looking forward to today's discussion. And I'm going to open it up with a question that any of you can address or answer if you'd like. We know that the environment in which technology is built influences its function. So for instance, data within a consumer technology are often very different than those seen in healthcare. So are we missing technology or are we missing systems of governance that could help address the issue of data representations that we see today? And any of you can start if you'd like.
I'm happy to kick things off and people can disagree or agree if they want. I think, at least to me, the key difference, and most of the technology that we use at the moment has been built from the perspective of consumer technology dealing with data about an individual that's on your phone, that is yours. And healthcare is quite different because, healthcare, you have real benefits to society from working on data analysis. And, the data itself, it's really difficult to say that any one piece of healthcare data represents solely one individual. And yet all of our, both not only from a technology, but from a governance standpoint about how you decide what you're allowed to work on with data, what you're allowed to use it for, is built from this individual perspective. So I think what we're really missing is taking a more collective approach to this. Ultimately in the research world, the idea of ethics committees and taking a more kind of collective approach to whether or not a particular use of data is acceptable is well understood, but then that is locked within the research world and then does not pan across to the data that's not captured within the research world. And that non-research data, if you like, from modern consumer devices and from all other data sources is a far, far, far larger pool than the upfront informed consented medical research data that people typically work with. And so one of the things that I think is missing is not only the systems of governance, but then the technology to handle that data in a way that agrees with a more collective view of consent than the individualistic approach that we typically work with at the moment.
Thank you. Others?
I'll hop in. So it's really interesting. We had issues related to broad consenting of data in the early 2000s, in which global indigenous communities felt like signing informed consent forms that granted researchers access and use of their data for the greater scientific good, whatever that is, granted too much research authority onto researchers to decide what is a benefit to peoples. And it's really interesting. We had a shift in the field to more study-specific informed consent, in which participants had to be reconsented at every single change or iteration of the study design and protocol. That was considered a little bit logistically burdensome because, especially at the time earlier in the 2000s, and even still now, we really don't have adequate funding for participant reconsenting, especially for highly geographic mobile populations or remote populations like Indigenous peoples. So then we started entering this era of like big data and harmonization that required sharing and collectivization across all different types of data sets. And we shifted back to broad consent models without real due conversation about the harms that broad consenting caused communities to begin with. And it's really interesting because we started defining equity, data equity, and access in terms of researchers' rights to access data. So for instance, last summer, the NIH announced 2 huge endeavors, Bridge to AI and Aim Ahead, and they had ethical cores as part of those projects. But if you look at it, it really emphasized the FAIR principles of data governance, of findability, accessibility, interoperability, replicability. And if you read those principles, it really centers data justice and equity on researchers' access to the data and not really talking about how this impacts communities, especially diverse populations that we want to see represented in these data sets. So I think we really have to think more about, how are we defining data? For instance, does secondary data in terms of de-identifying data, is that adequate for data privacy? And if not, we need to maybe disclose those risks, perhaps disclosing risk for like on the group level for individuals of communities that are identifiable, because there is a risk for genomic profiling. And just really thinking about, as Andrew said, more communal governance models of data and also benefit sharing back to communities.
For those just joining the broadcast, our question for the panel is, are we missing technology or missing systems of governance that could help address issues of data representation we see today? Any comments from our other panelists?
I believe that this is coming from both sides, and we also have to actually think about the aspects that we can see in the data that we have, which is represented. And so one part of this is on the transparency side, how much we know about a data set, or data that's going in the community, either on the clinical side or on the machine learning side. And the other aspect is on the accountability. So part of this is transparency, we will see which kinds of information exist and in the data, is it representative or not, which communities are included in these data sets or data. And then the other aspect is that so how are we actually keeping people accountable based on the data that they're collecting? And for that part, we actually need more governance and policy to be made to actually ensure those aspects. But I feel like at the moment there is a gap between this two sets of research experiences and discussion and the regulation that exists.
Okay, great. I thought maybe we would transition the panel so that we can hear a little bit from each of our panelists about the work that they're doing. And then we'll come back again with some questions at the end. So we'll start with Crystal. At Arizona State University, you've done a great deal of work around issues relating to Indigenous data sovereignty and how to prevent the extraction of value from communities without their involvement. What are some of the ways that you've found that we can engage with communities towards issues that are important to them and not solely focus on the work or agendas of stakeholders in the healthcare system?
Sure, thank you. This is a great question. So Indigenous data sovereignty is just the right of Indigenous nations, communities, and peoples to exercise authority, agency, autonomy about the data that is effectively about them and collected from them. And when I entered into this space in terms of health inequities, I realized that we really didn't do a great job with engaging communities in the process, in the research process. And we are missing out potentially on an opportunity to better design studies that directly relate to health issues that Indigenous peoples are interested in. One of the endeavors that I'm really grateful to start is the Native Biodata Consortium, which is an Indigenous-led biological data repository and 501c3 nonprofit with Indigenous scientists and community members at all levels of the governance of the organization. And when we started working with tribal leaders and community members, what we learned is that tribal leaders in particular were sort of reticent to engage in federally funded research because of the requirement to deposit data in a repository that's publicly available and accessible. And there was concerns that this perhaps, again, granted too much authority onto not only researchers, but also industry partners accessing the data set. Because now we have to talk about the increased public-private partnerships and what industry partners are perhaps getting out of access to public data sets, especially when you consider that, for instance, 23andMe and Ancestry have really profited heavily from their access to openly available Indigenous biomarkers through the Human Genome Diversity Project and 1,000 Genomes and other projects. So what we want to do is provide an alternative so that that data could be deposited somewhere under tribal data governance and jurisdictions. But we also knew that when you think about data in just terms of the genome and the EHR record, we're missing a lot of information about factors that contribute to health inequities in Indigenous communities. We're missing environmental factors, colonial factors contributing to disease, structural inadequacies related to health. And really the way to get at that type of data and to reduce the amount of missingness in those data sets is to work in conjunction with communities with survey and qualitative research approaches. And when we do that, we get better research questions because I'm saying this lovingly of genetic epidemiologists, but sometimes they treat race and ethnicity and other population identifiers as a covariate in data sets. And they already have sometimes their pet phenotype of interest, and then they just kind of want to ask about, in terms of disparities, they just throw on the race ethnicity portion onto a data set that's already pre-existing. And then they're really trying to structure the question related to health inequities in a research question that may not even impact or relate to Indigenous peoples, because they are the ones that have been living in conjunction with our changing environments and diets and lifestyles for the last 100+ years or even longer. So they're able to provide us with better research questions. And then just being openly transparent about what are the interests in research partners that want to work with us. And I'll just give you one more little quick tidbit, because I think it completely exemplifies why we need to be transparent with research interests. So when we started our organization, unsurprisingly, we had a number of pharmaceutical companies that wanted to work with us. And one question that we sort of posed back to them was, how about this for a novel concept? Why don't we use Indigenous people's genetic information to study conditions that affect Indigenous peoples? And then the pushback was, and we knew this to be, this is going to be the response anyhow, is that Indigenous peoples constitute like 3% of the general population. We don't constitute a profit generative a cohort to be able to do that research. And when you think about that, right, when we're defining benefits and democratization of technologies among who benefits first or most, right, then we're always going to disenfranchise communities. So we really have to think about the community benefit first, so that they're not just waiting around for decades, waiting for technologies to maybe one day somehow impact them, and try to think about bringing those benefits a little bit more proximal so that you can build trust in the research process earlier on.
There's a lot of lessons learned in your remarks there. Thank you so much. David, I'd like to hear about your work at Stanford D School. I know you work in the field of healthcare design, and some of what you do is stepping back from assumptions and observing how care happens, and then you start asking questions. So what are some of the ways in which this methodology helps communities who don't normally interact or engage with the healthcare system itself?
Yeah, so at the D School, we are primarily teaching. So we're teaching students from all over campus, design methods and tools and approaches, and also ways to collaborate and kind of intersect their different expertise. And a lot of the foundational work of these design projects is like you said, checking your own assumptions, recognizing that the expertise is not in this room, that we need to be connecting with the people we hope to impact and the people we want to design with. And so that means actually having a relationship with the communities that you are designing with and that you're a part of. And that relationship needs to be real and longitudinal and not purely transactional. So I think there were actually some great examples from the previous panel, specifically Mitch Lunn, when he was talking about the Pride study and talking about having, essentially advisors that are part of that process over a long period of time. They are paid for their time and their expertise. There was, also here recognizing that even though you might be working within healthcare, healthcare isn't just at hospitals and in clinics. Healthcare is everywhere. So where is healthcare happening? Where are those conversations being held? So another great example from the previous panel, Italo Brown talking about working in barbershops. So recognizing that you need to actually go where the meaningful work is happening. And I think there's also, an element here of thinking really intentionally about how you are engaging. What types of questions are you asking? Even simple things like avoiding leading questions can seem like, I don't do that, but like listen to yourself. Part of even what we're teaching our students is like how to create a question that is not leading. So recognizing that you as a designer are bringing biases and bringing power into that dynamic. And so kind of checking that power and making sure that you're cognizant of that throughout the process. And then I think there's also real work to be done in recognizing like you're not trying to extract data from a community, you're trying to learn from that community. And that means that you're learning a lot of things. And that means you're going for stories and details and emotions. You're trying to get that actual context that is meaningful to your work. And that can be a little bit uncomfortable for folks because they don't necessarily see a direct line to what they're asking or trying to learn about, but you're really giving yourself a chance to go into an abstract space and really entertain lots of possibilities, knowing that also in healthcare, so much of people's lives informs healthcare decisions. And so you have to actually understand that and hear it from them and make sure that you're not assuming anything about their perspectives or experience. And then just to kind of echo again, these relationships should be longitudinal. It's not like a jump in, get your insights and leave. And thinking about how to, involve the communities in the design process. So there's, lots of work being done around co-design. What are the methods and tools for that? A couple folks I would look at, Tanya Anaisi, a D School colleague who now has a design firm called Betna Design. Antoinette Carroll has this design firm called the Creative Reaction Lab based in St. Louis. And so they're also kind of pioneering a lot of these methods and tools and kind of an equity-centered co-design approach with communities.
That's great. And as a follow-up question from the audience, how can people working in healthcare gain new perspectives and inspiration to inform their work?
Yeah, so I mean, I think there's lots of qualitative methods that come to bear. So a couple of things come to mind in terms of like immersion and observation. So recognizing, which I'm sure a lot of folks on these panels and in the audience recognize, that it's not all going to be in a paper. It's not all going to be in a graph or hard data. That you actually have to kind of experience what people are experiencing, do it yourself. See how that's impacting your own, emotional state, And then there's also something about getting outside of the direct space you're working in. So looking at opportunities for analogous research or analogous inspiration. So a couple examples of that, if you're trying to understand some dynamics in an emergency room and how a team works together, you might try to find a place where there's kind of a similar level of intensity, noise, the need for a team to work together. So you might study like a NASCAR pit crew, like how are they communicating in this really kind of like immediate, race to get something done. I'm doing a project now in the election space, and we have an election official who actually intentionally goes to Black Friday sales to see how does a store set themselves up for an onslaught of lots of people, and then he uses that to inform how he sets up his polling place. And I think there's also something in the kind of ideation and concepting process of really asking good questions to inform your ideation or brainstorming, thinking about different constraints, and also making sure that the perspectives and the voices of the people that you are designing for and with are part of these processes throughout. So you're not just kind of generating ideas to present to people, but they are part of that creation process.
Thanks. So let's move to Alcir. You do some really interesting work with the Economist Impact to better understand the intersectional nature of health equity and digital health. Are there particularly high yield areas where we can begin to build infrastructure that will allow us to better address data gaps?
Yeah, that's a very good question. So I think that there's a lot of focus on physical infrastructure. It receives a lot of attention. But one important factor that we often lack to understand, or sometimes it takes the backseat, is what we call social cultural infrastructure. So I think one of the underlying themes so far that I've heard, at least from this panel and the previous panels, is the importance of trust and the importance of community involvement. And I'll take this one step further. When we talk about social cultural infrastructure, we're talking about policy, collaboration, partnerships, processes. It's often the intangible. So what I personally argue, and what we've been seeing so far, is that we need to improve actionable and impactful partnerships as well as policy. It's actually good that today we're becoming more aware of the importance of equity in health systems. And I know that Dr. Andrew Marshall from the last session, he talked about how every tech project will have an effect on equity. And he's right. Tech is part of a larger ecosystem where it can be influenced and influence social, cultural, and political factors. If we stop for a second and think about currently in Congress, there are a little bit over 5 legislations that are being introduced to have a direct impact on health equity, which can have a ripple effect on data. So for example, there's one specific legislation that looks at the expansion of Medicare and Medicaid coverage of prescription digital therapeutics with the purpose of expanding access, which could increase utilization of technology and expanding data sets. So another example of social cultural infrastructure that I'm talking about is forging partnerships for the expansion of diversity, inclusion, and equity in clinical trials. So this intangible, the process, the trust that is involved, the involvement of the community, the patient's voice is critical. It is definitely critical for us to build upon rather than just focusing on physical infrastructure.
Well, from your global research, how have other countries encountered the same problem of absent or missing data? How are they addressing this issue?
Yeah, that's a good question. So let's talk a little bit about Brazil. So unlike the United States, Brazil has a universal healthcare system called Sistema Único de Saúde, or SUS. So in the 90s to early 2000s, the Ministry of Health actually created DataSUS, which is this database that collects data from their public health system. Now, they've accomplished a lot over the past decades. They've done a lot, but there's still several challenges, which, if we compare it to the United States and other countries, we see an underlying theme. Like, for example, in 2020, I watched a panel with the Brazilian Public Health Association about the role of health and surveillance in the COVID-19 pandemic. And one of their researchers from Oswaldo Cruz Foundation, Fiocruz, they reported that Brazil was facing actually serious problems in data collection and data processing for decision-making because there was a lack of standardization of data, as well as they estimated about a 20-day lag between when patients reported symptoms and when data became available in certain states. And this lag was something that was confirmed by the OECD, as well as the Lancet Regional Health in Americas. They reported a similar study. So we've been seeing that this has been a continuous theme. And Brazil faces a lot of problems. And tying back to the equity answer that I gave most recently, there's also serious regional problems in Brazil with the healthcare system. The northern part of Brazil has a more underdeveloped system than the south. So then you have an imbalanced collection of data. So that's what we've been seeing so far in our research, specifically as it pertains to Latin America.
Okay, great. Thank you. And we'll move to Nagar. You're already getting questions from the audience before I can even ask my question. So this is a popular panelist here. But I'm going to start by acknowledging that you've worked on a spectrum of machine learning issues at Google, and specifically on Health Sheet for transparency and accountability in health data collection. Maybe you could begin by talking a little bit about that work.
Sure. Yeah. I mean, the questions are actually also like some of them are related to the Health Sheet and Data Sheet. So basically what we did was that Data Sheet is a framework that's used significantly in the machine learning community. And people in the machine learning community acknowledge that there are some issues with this, the way that we are collecting data, we are using data, and we are distributing data and maintaining data. But this is so in healthcare, like, I mean, as I brought up, there are so many regulatory frameworks. But there are some gaps here. There are some gaps when we're working with machine learning systems. For example, HIPAA does not mandate ethics review for data collection and downstream use. Also, it doesn't place any limit for the use of de-identified data, regardless of who controls this information. GDPR and the California Consumer Privacy Act also focus on notification, consent, and deletion rights. But this doesn't necessarily address issues about the ethical collection, documentation, and use of data. So when we're working in this intersection of machine learning and healthcare, which is something that's going on for a long time, so we need to actually care about, like, make it very contextualized. So data sheet that was brought up in the comments was like broadly used in the machine learning communities, but we wanted to actually specialize this and contextualize it for healthcare applications and for healthcare related data. So what we did, we brought together a team of experts from very, very diverse backgrounds, and we did a set of interviews with them. So we wanted to actually specialize Health Sheet for specifically for healthcare, the Data Sheet for specifically for healthcare that we're calling it Health Sheet. So we brought legal and regulatory experts, clinical, ML for healthcare, health data infrastructures, product, bioethics, equity, privacy, and socio-technical research. And wanted to see, like, from healthcare perspective, what are the aspects that we're missing in data documentation, even within data sheet. So one of the aspects that I wanna, like, so there were so many aspects that we diagnosed that you could actually read more about this in the Health Sheet paper, Health Sheet for Health data sets that was presented at FACT this year. But I want to talk about, like, one of this aspect, which was actually brought up earlier, about, like, this collection and use of racial information. Yeah, I mean, we know that, like, racism and social conditions have had fundamental impact on the causes and prognosis of many diseases throughout the history. And this was more evident during COVID pandemic. So on one hand, given the sociocultural factors, this can significantly affect healthcare condition of BIPOC population. Collection and access to demographic information is critical in conducting fairness analysis over ML healthcare models. On the other hand, modern American medicine has historical roots in scientific racism and eugenic movements and racialized conception of susceptibility to disease persists, which we actually can even see nowadays. So it's very important. Like, one of the aspects that we actually discuss in Health Sheet is what's the reason behind collecting this information. If you are not collecting this information, so that could be very harmful, because you would be able to, the danger and the harm that it can create is that you can test if your model works for underrepresented population in your data. And if you collect this data, what is the purpose of the research? do you know the intended use of this, and what are the kind of like practical guardrail you can put for use of this kind of information and this kind of data. But like beyond this like racial information and racism and collection of demographic information, so we also have other aspects with health sheet that we were discussing and we address, like dataset versioning. For example, we have some data sets which are dynamic, like data sets which are online, like for example, on data sets that we tried, like one of them was mimic dataset, mimic tree dataset, that has different kind of like versions. But we also have data sets which are very dynamic. For example, like MS-OAC data set that we were working with, which is an app data set related to multiple sclerosis. And the data is updated every day. I mean, earlier than every day. So we wanted to kind of like keep the track of this information. So if I have a data sheet, if I have a health sheet for this version of this data, so which kinds of changes I'm making and how is the impact of them? Is there any other questions related to this that folks ask? I've heard about it.
Yeah, I think there were a couple in the comment box, but I think you addressed each of them.
Good. Yeah. Sociocultural information in your data sheet. Well, yes, the sociocultural one, which basically like we are not addressing so like all kind of sociocultural aspects because of like the way that we can't really like ask about collecting some of this information. But the information that we're addressing is usually like on the demographic side. But we acknowledge that there are so many other proxies that could impact this information. So we want people who are filling the health sheet to also acknowledge this. And now we are working on the extension of that more with clinicians to make health sheet more accessible to clinical use.
Okay. Well, great. Thank you. Now that we've introduced each of you to our audience and each of you to one another, perhaps we could have a bit of discussion. I'm curious if any of you have comments on other panelists' remarks or questions for one another before we turn our attention to the audience questions.
I did actually have one comment just about Nega's work on Health Sheet, which I think is a fantastic idea. I think many people kind of forget just how nascent the software engineering industry is and how quickly it's evolving. And so a super hot topic in the software industry at the moment is this idea of supply chain security, the idea that a single software system that you use day to day is actually made up of thousands of different subsystems written by other people in different companies, some of it open source, some of it not. And that's increasingly becoming problematic from a security standpoint. And I think there was an exploit late last year in a piece of software called Log4j that just is used by people running software to monitor its behavior behind the scenes, that caused many companies all over the world to turn off systems for multiple days while they worked out what was going on. And the root cause is engineers typically just don't know what is going into the software that they ship. And ultimately the economic impact of changes like that has pushed that to the top of people's minds. And there's a lot of practical work going on at the moment around this idea of software bills of materials, tools to work out actually what is running inside this piece of software that I'm using. And it strikes me that maybe there's an opportunity to actually kind of jump on top of that with this kind of health sheet idea of saying, while we're at it, while we're actually trying to understand what is part of this piece of software that I'm using, can I also aggregate up the properties of any machine learning or database components in it to make sure that they actually align with the ethical standards that I'm committing myself to. So that to me sounds quite exciting and seems like an area of interesting future work.
Thank you so much for talking about this. This is actually so. I mean, like in software engineering, like as much as difficulty and issues that exist within the software engineering community, we could kind of like amplifying it with talking about machine learning, because many aspects of that is kind of like black box, and we still don't know about like the way that systems works. So part of this whole shit is actually talking about the data composition and where are the sources of the data, and specifically like how they are connected, or like how we are using different parts of this data, or like on different kind of like versions, or if this is coming from another subset. But another work that I wanted to mention, which is a recently submitted paper that we haven't like put it on archive yet, but we are planning to actually publicize it in a couple of days, is around using reliability engineering and safety engineering tools for machine learning research. And see, like, I mean, in like when you're creating a plane, there are so many safety aspects and rules that's going on into the place in order to be able to make sure that each aspects of this is actually evaluated well, tested well, and it's working together really well. So how can we do the same kind of test and evaluation on machine learning systems? And then when we are working with machine learning systems, specifically working on socio-technical aspects, sociocultural aspects, and ethical aspects of this kind of systems. So we actually chose two tools, which is called STPA and FMEA, that was broadly used on safety engineering. And we research around the applicability and use of this kind of systems for a machine learning system, and how we can actually trace back issues that can happen if you're using this kind of systems. And I feel like healthcare applications would be something which is definitely one of the most needed use cases of this kind of models, if we can kind of like understand how to apply them to understand the ethical aspects in machine learning systems. So please stay tuned, like it will be coming out in a couple of days.
Congratulations, that's wonderful. We do have a question from the audience member, but I do want to offer our other panelists any additional questions of each other or remarks. If not, we'll turn to our audience question. Nikish Mishra asks of the panel, in general, what big picture steps can we take to avoid misuse of data in the future? This being a future-focused panel.
I have one, partly actually inspired by Nega's talk there about safety engineering. If you were around for the little talk I did at the start, I mentioned this case of Latanya Sweeney, which I'm sure lots of people have heard before, about the re-identification of the Governor of Massachusetts records. It is one of the classic cases of how anonymization isn't actually anonymous. What people don't actually talk about too much is that it took her 10 years to publish that work. And it took her 10 years to publish that work because nobody would publish it, because they were scared of the legal consequences, and there were court cases brought, and it was a pretty difficult situation. And I think that is a real difference between the clinical world and other worlds. You know, if you look at, let's take, for example, transportation safety. If there is an air crash or a plane crash, the first thing that happens is you have in the US, the NTSB, the National Transport Safety Board, analyze things in a blameless way, and actually try to look at the systemic issues that led to that event, and work backwards to ensure those things will never happen again. And kind of move forwards. Whereas typically in the clinical world, you know, if a clinician makes a mistake, they're struck off and cannot work anymore. And I think that leads to a pervading culture of not being honest about when failures occur and when misuse occurs. And I completely appreciate that the risk in the clinical world is totally different to others, and the context is totally different. But finding some way to embrace this idea of talking openly about when bad things happen, I I think is being proven in industry after industry as a way that you prevent bad things from happening. And finding some way to change that at a large scale. Obviously, being a big picture ad set, I've got no idea how you do that. It just strikes me as a difference between those worlds.
If I could jump in really quick, I wanted to take this back to the governance conversation we had earlier on in the panel. And we do a lot of research in so many different topics in health systems, from bone health to digital transformation, you name it. That's what we do. And it seems like an underlying theme in all of our research is the importance of patients' voice and including medical professionals in the decision-making process. From a governance perspective, I mean, if we just look just for an example, for metastatic breast cancer, if you look at cancer registries around the world, and the reporting of data, it's alarming to see the difficulties of data collection, the difficulties of data sharing, and sometimes it doesn't actually represent the situations that patients are going through with different social determinants of health. So sometimes I think it's critical for us to, the big picture step to include them in the conversation, being intentional and not just adding them to the table, but actually being intentional in making sure that they have a voice in how data is protected and how their data is used.
Other thoughts? Alcir, I have a follow-up question that's related. How can we ensure that the design and subsequent impact of technology is just more inclusive in general for data collection?
That's a good question. And I don't know, I think David would probably be a great person to ask this question as well. But I wanted to answer this from a different perspective, from the health technology assessment perspective. Every country has a different process, right? I mean, some countries have a formal process, some countries have a national process. So I think one of the things that are extremely critical is, like I just said, is the inclusion of equity as an underlying factor in the decision-making of health technologies. That doesn't exist across the board. I mean, I read a study in the Israel Journal of Health Policy and Research, and the title was kind of striking. It said, "Equity in HTA, what doesn't get measured gets marginalized." And I think that raises a very interesting point, because once we look at the HTA process and all the data that is collected, it tends to focus on cost effectiveness and safety and so many other aspects of the medical, pharmaceutical or some sort of medical intervention. But the social aspect of equity is not often measured. And I think this is a very difficult thing to do, which raises the question, right? How do we quantify health equity? How do we quantify its impacts not only within the health system, but if we talk about the social determinants of health, how does it impact all the other determinants? So I think that there needs to be conversations of ensuring that this is something that could be included into the process and becoming a formal process within an HTA. And for that to happen, you have to include the community. You have to include people who are directly impacted by that. I'm not sure, David, if you would agree with me on that.
Yeah, I think that's right. I think even just like this conversation and like the issues of equity, like just need to be more of like the foundation of any research project. And I think there's also something about recognizing like the team. This is not just about like how are we accessing equity out in the world, but like is the team that is designing this work representative? How are you recognizing again like the identities that are part of that team and the power that you're bringing into that space, and being explicit about that and being part of the way that you share your research. I think there's also the element again of in terms of the community being involved in your process. I mean, check in, like, how is the community receiving and responding to the work that is being done, and actually creating the space to have that conversation and not make it kind of something that was done at the beginning, and we hope it works out, but holding that accountability throughout the project.
Well, thanks to our panelists. We're at time now, and this has been a really great conversation. It's been an honor for me to get to meet each of you and hear about your work. So thank you very much for your thoughtfulness and your expertise today. And just as a note, we have a conference hashtag Stanford MIA, hashtag Stanford MIA. If you'd like to continue to ask questions or have a conversation on Twitter, we certainly can. But we're going to transition to our final speaker of the day, which will really be outstanding, Dr. David Magnus. I think we'll tie all of this interesting conversation we've had today together. And I encourage you to stick around for his final remarks. But thank you very much for this wonderful panel.
Thank you very much. So I hope can people hear me? I'm going to assume if I haven't gotten a message that I haven't, I assume people can hear me. So thank you very much for having me here. Great pleasure to be here. I'm going to be talking about a few things here today around some of the issues around missingness in data and some possible solutions. I do have a disclosure to make. I don't think it's a financial conflict of interest, but I do have potentially a conflict of commitment for some of the things I'm going to be talking about because I'm the co-chair of the IRB for the NIH Precision Medicine Initiative All of Us Research Program, which I'm going to be talking a bit about. But I want to note that the statements I'm making here are the views of my views, not necessarily the views of the IRB or of the program. So obviously, when it comes to research, AI research to try in health setting of healthcare, there are a number of sources of data. Consumer data collected actually outside of healthcare is an increasingly important one, and that's a very large issue because it's so unregulated. And of course, there's lots of issues around the secondary uses of data collected for other purposes like electronic health record data, insurance claims, newborn blood spots, census data. But I'm going to talk about research repositories. These are data that are collected explicitly for the purpose of carrying out research. And there's an increasing effort to try and build these research repositories. Some are very small with very large amounts of data, like Project Baseline at Duke and Stanford, partnered with Verily, where they have 60,000 participants, I think, in total, who have agreed to be studied quite extensively. There are disease-specific research repositories or biobanks. There are healthcare systems that have their own. Geisinger Health in Pennsylvania has one of the most comprehensive for their healthcare setting, healthcare system. Kaiser has one. We have several at Stanford. And then there are these very, very large research repositories. The UK 100,000 Genome Project now has vastly exceeded 100,000 genomes. And the NIH All of Us Research Program that I'm going to be talking about a bit more in detail is an effort to pull in 1 million people who will be sequenced, have access to electronic health records, survey research, and a whole lot of other stuff. I'm going to just give an example of what you could potentially do with this kind of data. I'm sure you've got a million examples, but I want to come back to this one later. Patients present for palliative radiation. Right now, physicians, depending on their condition, bin them for radiation versus palliative care and how aggressive the radiation is by essentially dividing them up into the patients who are going to die within 3 months no matter what you do, patients who, if you give some radiation, will live 3 to 6 months, and patients who will live 6 to 24 months who you want to be more aggressive with radiation. Physicians' binning of those patients into those groups is actually really poor. When you ask physicians in advance their estimates of patients' survival and then look at the actual data, they're terrible at it. And it turns out machine learning, looking at fairly large amounts of data, are better at putting patients into the appropriate bin, allowing better and more precise treatments. So, for example, for patients with metastatic bone disease, Sarah Alcorn at Hopkins has developed a nice algorithm. Here at Stanford, some folks just using regression, large amounts of regression that of the sort that machine learning can do with thousands of variables, looking at a wide range of patients, was able to develop something that was much better than physicians. And of course, there are similar predictive analytics for other domains, transplant listing decisions, who should go to the ICU, and so on. Now, one of the big problems with all of this is, especially when it comes to doing research on research repositories, is the unbearable whiteness or Eurocentrism of studies. And this is particularly acute in genomic studies and genome-wide association studies. A paper published by Alice Popejoy and Malia Fullerton, following up on an earlier study from 2009 by Carlos Bustamante from here at Stanford, I think demonstrates well the problem. That number on the left was from Carlos's earlier study, which showed that 96% of GWAS studies were from people of European ancestry. Originally, the article that Alice and Malia turned in had an equally depressing number because they were really just focused on GWAS studies in the US, and the number on the right was, I think, 93%. So it had moved a little bit, but not much. And the publishers thought this was so depressing, they insisted they make it international, so that marginal improvement from 96% European ancestry to 81% really mostly reflects the fact that there are a whole bunch of GWAS studies that took place in China and Japan and represent the vast majority of that other 19%. But GWAS studies have almost all been in populations who are people of European ancestry in this country, and then in some Asian countries, people from those countries, but very few people who are have African ancestry or people who have Hispanic ancestry. And obviously, this represents a problem for justice of the sort that you guys have been talking about all day. If populations are underrepresented in studies, the AI systems will be unable to accurately make predictions that can benefit those populations. And in addition to race and ethnicity, I want to highlight there's other aspects of diversity and other underrepresented groups that are also important, including socioeconomic diversity, gender identity diversity, and especially patients with disabilities who are systematically underrepresented in research. And some of those populations may be even harder to obtain and include. So what's the solution? So one question to ask is, can IRBs help? Can IRBs come to the rescue? But I think it's important to recognize that there are limitations to regulation. So if you look at the origins of our regulatory system, both here and in most of the rest of the world, here in the US, it's the Belmont Report, and the rest of the world, it's Helsinki. The focus is really, when you think about oversight and regulation of research, it's really on the risk to subjects, not society at large. What IRBs typically do is look at making sure that risks to any research participants are minimized, that risks are reasonable in relation to anticipated benefits, and that there's adequate informed consent. That's pretty much what IRBs spend most of their time doing. And when it comes to building research repositories, for the most part, those are seen as minimal risk. And so it's pretty easy to meet those standards if you're building a research repository, as long as you have adequate consent. Now, IRBs are also charged, I'll come back to this, with equitable subject selection, at least in principle. But the reality is that is something that IRBs have really not put a lot of effort into. What IRBs don't do under the common rule in the US is consider possible long-range effects of applying the knowledge game in research. So the possible effects of the research on public policy, downstream social impacts, those are risks that actually do not fall within the IRB purview. And so then that raises the question, when it comes to the fact that groups are being underrepresented in research, which way should we look at this? Should we see this as a problem of not an equitable group of subject selections, or should we see this as something that's outside of the IRB purview because of its impact on subpopulations? Up until now, the way IRBs tend to think about it is they don't want explicit discrimination, but as long as you say it's open, that's pretty much all that's required. And there's usually no effort to try and hold researchers' feet to the fire to meet any kind of target. So if you say, gosh, it's open to everybody, and we're hoping to be diverse and represent the diversity of the community that we're drawing our biobank from, and then it winds up being, like most of these biobanks, all people of European ancestry who are middle class and affluent and not disabled, then nobody really historically has paid a lot of attention to it. And the fact that there are these systemic built-in discriminatory structures that explain why it is that you're having these outcomes, they don't really worry about it as long as it's superficially open to all. And that's really what most IRBs do and how most IRBs have functioned. But arguably, there you could bring under IRB purview, under the equitable selection of subject requirement, insisting that there be adequate plans in place from so that underrepresented groups will be represented in these research repositories. So when IRBs are reviewing these things, this is something they could do so that this problem is overcome. It means making sure that the pro forma openness, instead of truly requiring researchers to actually have concrete plans for how they're going to meet goals for recruiting from those populations, has to be in place. And right now, for the most part, IRBs have not done that. And I'll just say in a minute that I think the All of Us research program IRB has been an exception. In addition, I think IRBs can legitimately be concerned about the scientific value of research where the data is systemically biased. IRBs are required to consider the scientific basis for proposed research when evaluating risk and benefits with the proposal. Again, this is typically cursory for IRBs, and they often, if possible, allow other review processes like peer review for grants or FDA review to count as the scientific review process. And if you have unsponsored research going on, if you're building a research repository from internal sources, usually it's just a very cursory review by a department chair or a division chief who says this is fine. But if biases in data raise significant problems for the basis of the research and the potential for true benefits of generalizable knowledge is not there without adequate inclusion, then IRBs could require a scientific review process to ensure that there's not that bias in the data. So in theory, if IRBs can hold people's feet to the fire, and if this is something that researchers should be aspiring to when they put together a research repository, can it work? What's possible? And I think the All of Us research program is, I think, a model for, at least initially, for what can happen if you really put the effort into inclusive and diverse recruitment. This is obviously the All of Us program is a huge effort designed to recruit ultimately 1 million people who will be full participants, which will probably require several million people who will be at least somewhat participants. And this is part of the bipartisan 21st Century Cures Act. So there's been a significant amount of funding from NIH to support this issue that was earmarked by Congress for this effort. Participants in the All of Us research portfolio are asked, or this research repository, are asked to provide all or some of information that includes surveys that they're asked to fill out. And in fact, they're asked to ideally participate through time rather than just a one-off into the research repository. So they're making great efforts to try and not just recruit people, but to retain them. They have to provide access to their electronic health records. There are physical measurements that are taken. There are biospecimens that are collected for sequencing purposes. And then from a lot of participants where possible, they also collect passive mobile health data from things like wearables and phone, et cetera. And they're always figuring out ways of adding new data into the database from people. There are primarily two methods of engagement. Direct volunteer program is people who just read about this online. Any of you who are not participants can just go to the website, sign up, and then there can be some challenges sometimes in being able to get your samples in, but you can, in theory, sign up just through the direct volunteer program. And then I would say most of the people who are participants come through a large network of health provider organizations, including FQHCs, that are sites where research participants are recruited by researchers who have grants to do that recruitment at each of these individual sites. Let's see, and then this says this is some of their core values articulated, and that reflects the 21st Century Cures Act, in which they're really designed. The whole point of this biobank was to try and create a diverse cohort that includes a broad range of participants, and it's really deeply embedded in the program. And I think it is deeply embedded in the program and its values. So what works? What makes it possible to even think that you could actually make this recruitment possible, given the abject failure of most efforts to build diverse biobanks. I think one thing that makes a difference is holding people responsible and accountable. So to the great credit of NIH, the sponsors have really held people's feet to the fire and said, you have to do this. And so has our IRB in the very early days when there was a race to try and get people recruited as quickly as possible because of the transition in administrations from Obama, where this was launched, to the Trump administration. There was a real effort by some folks to try and race and think we'll worry about the diversity later. And IRB was just not having it. And I think the leadership of the program was behind that as well. And so that meant really saying like, what is your plan? How are you going to guarantee to us and satisfy to the IRB's satisfaction that your plans to recruit diverse populations? You told us that your particular HPO plans to have 50% of your participants be African American or Black. How are you going to do that? How is that going to happen? Then one thing that also helped greatly is as these different HPOs, these health provider organizations, figured out what worked in recruitment, every time they figured out something that worked really well, they shared it with each other. And that includes figuring out what they needed to have as their plans in place in their protocol submission to the IRB so that we would say it's okay. And then there are just some obvious lessons. Recruit where groups that are underrepresented in biomedical research actually get their care or where you can find them. If you're at an academic medical center in Palo Alto, can't be that surprising that it's not going to be that easy to recruit people to a very diverse biobank set up at Stanford. So it's important to go where they are. So that's one of the reasons why it was so important to partner with the FQHCs. Also, build partnerships with trusted voices and institutions and communities. And I can't stress how important that is. A lot of the success of this really hinged on each of the HPOs and the program as a whole, building deep ties and partnerships with the communities that they're going to be recruiting from, so that they're full partners in the research endeavor, so that you can actually make this successful. But that all takes a lot of effort and a lot of dollars to be successful. But they've demonstrated, I think, that if you make that effort, it can work. So I think in the end, the proof of the pudding is in the eating, right? So to date, so far, they've got 531,000 plus total quote unquote participants. 392,000 samples for sequencing have been collected. 372,000 have completed all the steps to be a full participants. That is, signed the consent, provided samples, provided electronic health record access, and completed surveys. There are 322,000 electronic health records that are in this database. But you can see 50% of the makeup of this 372,000 person cohort and counting on its way to 1 million. 50% are racial and ethnic minorities, and 80% come from underrepresented groups in biomedical research, UBR populations. And just giving you the more detailed breakdown, you can see that almost 20% of the participants are Black or African American, 16.5% are Hispanic, Latina, Spanish. Another 6% come from one race or ethnicity. A little underrepresented for Asian population of 3%. The national representativeness would be 4%, so that's a little bit underrepresented. And then, of course, we know that age is also not equally distributed. And so there's been an effort to include older patients who are systematically underrepresented in a lot of this research, and to get a broad spread and do all the things to overcome obstacles, including for people who can't leave their homes, who are disabled, going to them and bringing these efforts to those populations. Now, I just want to end, I don't have much time, with asking a question. So it's great that it's possible, if you make the effort, to get more inclusiveness in the data, and I hope IRBs will hold people accountable for that. But will inclusiveness in the data actually result in less inequality? There, I'm a little more skeptical. First of all, a lot depends on how it's done and whether or not you can build trustworthiness in the population. I think that's at least something that could be overcome. But how do we make sure that the promised benefits for UBR populations are actually realized? And how do we make sure that more data does not lead to greater inequality and discrimination? And I'll just highlight 2 problems. First of all, the fact that there's biases and prejudice in current clinical practice means that that's embedded in electronic health record data, which can lead to self-fulfilling prophecies. For example, this is an area that I've published a lot of studies on, and my team has worked on. Many transplant programs don't list, for example, developmentally delayed kids or adults for that matter, even though they have just as good outcomes in terms of graft survival. Similarly, undocumented immigrants, even though they have better than average outcomes in terms of graft survival, it's an absolute contraindication at about half of transplant programs in the US and a relative contraindication to most of the rest. And there are lots of other ways in which there's biases that are embedded in the data. And as a result of those patients die at higher numbers. And you don't see this just for transplant. You see this for decisions about what kids get ECMO and who gets operations. And so there's the risk that algorithms can learn that outcomes are poor for people with these different traits. For example, if they have organ failure or if they're very critically ill, the algorithms will learn because those outcomes are worse. And that's because of choices that are made by clinicians. And therefore there may be a reinforcement and reification of current biases in physician behavior. And more data won't make that better. And then in addition, lastly, accurate differences in health outcomes. So those other ones were biased because the outcomes are just as good, but they're bad just because of the decisions. But they're actually accurate differences in health outcomes, but they're a function of societal injustice. Accurate differences in how we know there's a health wealth gradient. At every wealth gradient, you're sicker and more likely to have a shorter lifespan at every gradient as you go down the wealth gradient. And you get similar, even if you keep wealth fixed, you have similar things for racial and ethnic groups. And what that means is our first example, when we talked about people who are presenting for palliative radiation, you're going to have disproportionately poor people and people of color in the group that's got 3 months or less to live, and people who are white and more affluent are much more likely to be in the group that's going to live several years. And it's like this for almost every condition. And so that's one of the problems, that's something that's accurate. And there are ways in which maybe we can put our thumb on the scale to balance that out, but it's not always clear that that's going to make things better. And so that's another worry I have, that those inequalities in society are going to just be, again, reinforced and reified by the results. So while I think the data has promise, and I think it's important to not leave people out, having these voices missing is a problem. It's important to note that that is not a panacea. Having the data from these underrepresented groups is just a start for a lot of really, really hard problems to really make it equitable and to make things better for those populations. And I'm sorry I went 1 minute over. Thank you very much.
Thank you, Dr. Magnus. Thank you, everyone, for joining us here today. I'm here in the studio with the rest of the MIA crew. Thanks again for being with us. And if you want more information or would like to follow up, please visit the website, stanfordmia.org, for any more information. And don't forget to use the hashtag #StanfordMIA. Thanks again.